selected as the theme for World's Patient Safety Day 2022. To commemorate the day, WHO is organizing a global virtue event calling on all the stakeholders to join efforts globally for medication without harm. So in this regard, Integra Ventures have organized this MDP to create an awareness and encourage among the healthcare professionals to enhance patient safety and reduce patient harm. Today, I, Lipika Sharma, shall be walking you through the MDP. I am extremely overwhelmed to get this opportunity to address you all. And before I invite the speakers of today's program, I would like to introduce you to the proceedings of this program. We'll begin the MDP with a panel discussion on the theme medication management is key for patient safety, followed by 6 sessions on varied topics related to medication safety. Our first panelist is none other than Dr. Harsha Bhattacharjee sir, and I would like to request sir onto the stage to share his experience and comments, which will add an important dimension to what is potentially a very important discussion for today's session. I request Mr. Sudipto Karmakar to felicitate our first panelist, Dr. Bhattacharjee sir. Next, I would like to introduce Dr. S. Jugindra Singh, Director of Medical Services, Shija Hospital and Research Institute, Manipur. He is the Indian Medical Association President, Manipur State Branch, and also a President, National and International Faculty Training Young Surgeons in the art of safe laparoscopic surgery of the Association of Minimal Access Surgery. I request Mr. Sudipto Karmakar to felicitate Dr. Singh. Next, I would like to introduce Dr. Soumar Dutta, Consultant and Coordinator in the Department of Emergency Medicine, Narayana Super Speciality Hospital, Guwahati. He is also the Patient Safety Officer of the organization's Guwahati unit and an instructor of American Heart Association program. Dr. Dutta's field of interest are pre-hospital care, medical surgical emergencies, toxicology and snakebite. Now I request Mr. Sudipto Karmakar to felicitate Dr. Dutta. Next panelist I would like to introduce is Ms. Purabi Das, in charge OT of State Cancer Institute. Ms. Das is trained in oncology nursing and in CVAD from Tata Memorial Center, Mumbai, and is also trained in essentials of palliative care under IAPC. Additionally, Ms. Das is also the GS of All Assam Graduate Nurses Association and is actively working for the upgradation of nursing professionals in Assam. I invite Ms. Das onto the stage, and I request Mr. Sudipto Karmakar to felicitate Ms. Das. Next panelist I would like to introduce is Dr. Ronit, Bora, a healthcare management professional with experience of working in the field of health insurance, hospital administration and quality control activities. He is a certified NBQP accredited healthcare and hospital consultant, certified NQS external assessor. Dr. Bora's key area of expertise lies in process improvement activities through quality control, establishing quality management system and conducting training. I request Dr. Bora onto the stage, and I request Mr. Sudipto Karmakar to felicitate him. I would like to introduce the moderator of today's panel discussion, Mr. Sudipto Karmakar, the co-founder and the senior consultant Integra Ventures. highly skilled management professional with diversified experience in healthcare consulting. He is also a certified lead auditor of ISO Quality Management System. I request Ms. Sangeeta Vaishya to felicitate Mr. Karmakar. Ms. Naima Tehri, you can come and felicitate Mr. Karmakar.
Hello. A very warm welcome and good morning to everyone on the stage. Along with me, the fellow speakers, panelists, as well as all the audience who has come today. Thank you, Lipika, for the wonderful introduction you gave to us, and obviously to Dr. Harsha Bhattacharjee sir, who has been always supporting us in various kind of such programs which Integra Ventures has been organizing since last 3-4 years. Today we are going to discuss on medication safety, rather patient safety in hospital settings as well as at community level. But in the year 2022, WHO has recognized this day to focus on medication safety, as medication safety is a very key part or plays a very important role in overall patient safety. So without wasting any time, I would start the session and would ask Dr. Harsha Bhattacharjee sir, like what will be, obviously he has spoken on patient safety a little bit ago, but I would like to focus on especially with regard to eye setups, or let's say ophthalmology, what kind of special precautions we should take in terms of taking medications or maybe administering medications both at the hospital settings as well as, let's say, at home or community level.
Thank you very much for asking that question. Now the audience which are here, they are of different capacity of their service deliveries are different. I think various, somebody may be delivering the medication, somebody may be the counselor, and some may prescribe the medication. So different groups of people have been assembled here. So I'll be more or less a bit generic than very much specific. Now, one incident I can remember, generally when I was working in the medical college, I tried to go first and leave the department as last, because eye care is more or less a daycare sort of city. So one night when I was coming from the hospital, generally I visit the emergency before leaving. Okay. One day a small boy at about 11 o'clock was brought to the hospital and his tongue is out. The tongue is out since midday. Their parents took him to the different situations, starting from the Oja, because in our society, when the medical system fails, they will go to Oja for treatment. Everybody of us has the experience. In the medical college, when the patient was brought, they generally, a young doctor met the emergency department and they were in confusion of what is happening actually. It is a type of dystonia, maybe due to many causes it can happen. When I elicit the history, I found that he has purchased a medicine across the counter. He went to a pharmacy and told that my son is vomiting, give some medicine. So he gave a strip of medicine, he gave his son this medicine. So I found this is a Reglan, a very commonly used medicine for stopping the vomiting everywhere, anywhere, across the counter, even anybody, a quack also knows Reglan is a medicine for vomiting, but that is causing side effect to it. Then I diagnose, it is a case of side effect due to Reglan, but you see, so much of harassment to the patient, so much of money expenditure, so much belief on superstition, coming here and there from such a long distance, expending money. So that knowledge. So what I want to say, that before prescribing the medicine, we have to know what is the side effect of the medicine. It is not for the medical practitioner, I think nurses. While I was in the medical training, my professor, Niyogi, he told me that previously there is style of writing a book, that's rare thing they will write below with small letter. Just like a religious book, they give an explanation below as a note. So you read it first. So I have that habit till today. Whatever small thing I read, and that time many times it helped me. So there I can remember the Reglan can cause protrusion of the tongue and some mechanism has been described for the treatment. So you see that a little knowledge gap has put the person into so much of trouble. So what I want to say, before prescribing the medicine, delivering the medicine, asking the patient to use it, we should have a substantial knowledge. Now you see hundreds of medicines there, many medicines are not of use, but which medicines are very much useful, we should make short list of it and have a thorough knowledge on this subject to avoid the patient the harassment. Another incident I can mention, that a drug, there is a prostigmine. Now that also in the emergency I have encountered. This prostigmine medicine, once the government is procured and before the expiry they have given to all the places, dispensary. So one drowning case came. When the drowning is there, you have to take the fluid out from the stomach by tube. We have to put the tube and drain it out. But that medicine is written, it can induce emesis. So the attending pharmacist, he injected it and he repeated so much of vomiting. Out of vomiting the person becomes sick. When I inquired, they said that it can induce emesis. I had no stomach tube, gastric tube, so I have used that one. So you see the lack of knowledge. So the main problem of medication, one of the main problem is the proper information about the drug which are in use. It is not only for general medicine, but it is for ophthalmic practice also. The medicines, what are the side effects of the medicine? What are the complaints the patient may have which is related to drug toxicity? So all these things we can find out and we can give or we can take prophylactic action. See, ophthalmological practice, what we find that after using the medicine, the proper instruction is lacking to the patient, because we have to tell the patient these are the problems if you may face. If you face, stop the medicine and inform us. So suppose anti-glaucoma medication, this may even reduce the blood pressure, and for that the patient again go to blood pressure treatment, other things. It is there. It happened to the doctors also. Not only doctors, to an eye doctor. They have flown to Delhi, suddenly the bradycardia occurred, suddenly everything has occurred. Point is that the proper instruction was not given. This is the side effect of the medicine. On the other hand, the attending doctor also do not take the proper history what medication giving. Nowadays, internet we can check easily that this medication has this sort of side effect or not. So these are some of the things. This error occurs in everybody's hand. So until unless we adopt a principle of protocol based or SOP based medication system, every of our team members, starting from the nurses to the counselor, everyone has responsibility. And what I have realized from my experience, the common people, if you say something, most of the things they do not register in their brain. So you have to confirm again that I have said this, you have understood or not, and what you will do, what you will not do. You have to tell the attendant also that this is the problems you may face, these are the early symptoms of the side effect you may face. Immediately you consult your doctor. I will stop by saying one example. That is the most horrible experience in my life. One lady about 30 years old, she came with blindness. She cannot see properly. On investigation, I found she has consumed that ethambutol medicine. I asked, where is your tuberculosis? She said, I had no tuberculosis. Why you have taken it? She told that my neighbor has given. Because she got cured when she was fever and other thing, she was prescribed that medicine and she think it is a good thing. So when after taking, her fever is not subsiding, she started, is the idiosyncrasy. Third day onwards she developed blurring of vision. Advice was, when there is a fever, people see less in the eye. Nothing to worry, you take it all right. Then ultimately it leads into irreversible blindness. It's a cumulative effect of the drug. So what is the problem? The problem is prescription of drug by unauthorized person. Delivery of the drug by the pharmacy without a valid prescription. Instruction and advice. In our society, big problem is everybody is a medical practitioner. In my opinion, the largest profession in our society is the two things. One is physician, another is the forwarding agent. Forwarding agent means when there is something in the WhatsApp, immediately forward it. So these are two largest professions in our country. So let us be careful. It is our responsibility to make the people aware. The medicine may act as a poison or it may act as a nectar. So it depends upon how we use it and how cautious we are. So with that I conclude.
Thank you, sir. Point taken. I mean, I'll move on to my left. Dr. S. J. Singh, Director Medical Service of Sija Hospital. Sir, I would like to ask you, like Sir Dr. Harsha Bhattacharjee rightly said, that many doctors, even hospitals, are not aware of many drugs which might be banned by the government, or there are certain new drugs which are coming in the market. Such awareness, such list of updation of drugs are not known to all the doctors or maybe the medical professionals on a regular basis. So how do you check on that, and as well as what kind of such precautions you might have taken in your hospital settings?
Thank you. First of all, I must thank Integra Ventures for giving me this opportunity to be here on this very important day and topic. Let me just narrate how this topic is important, as I think it is. So I would like to know from the audience, how many of you have traveled by flight? Please put up your hand. All those who have traveled by flight. So more than 50% have traveled by flight in this audience. How many of you ask, who is the pilot, before climbing the plane? Nobody. None of you are asking who is the pilot. But are you sure you'll reach your destination? You are 100% sure that you will reach the destination. This is because aviation industry has become so safe because of practices which have been integrated in their systems and management. And the chances of error is very minimal, 0.01%, which is almost negligible. So what are the systems that this industry, aviation industry, which is very dangerous actually. Whatever little error may happen can cause so much damage. So, but it has become very, very safe, and none of us are thinking twice to climb on the train, whether on the flight, whether it will arrive at the destination or not. But while we are all working in health industry, we have not taken this precaution, and we are not delivering that accuracy in safety. How much is the problem that we are causing? Different countries have different data. United States data says that 30% of the medical problems in America is caused by health workers. 30%. And those who have not, in this audience, whoever has not read the book by Dr. Atul Gawande, he has written an excellent book on Checklist Manifesto. The name of the book is Checklist Manifesto. I recommend that each and every one of you please read this book. It is by Dr. Atul Gawande, who is settled in the US. He is a surgeon, and he has written this book, and his recommendations have come in the WHO for safety in medical practice. And there are many practices that he has recommended which has been integrated by WHO to the entire world. So it is a very important book. You must please read it. So he says that by employing safety checklist alone, 30% of the medical problems can be reduced. 30% of the iatrogenic or healthcare related, health persons related problems can be reduced. So it is a huge number that we can bring safety by doing safety checklist only. There are many other methods. And this safety checklist is not only for medication, but the topic for today's discussion is medication, error and safety. But his recommendation goes along in so many other areas of practice. So I would recommend this, and this is why we have a collective responsibility to take up all the precautionary measures to provide safety to our patients as well as to ourselves. So coming back to the question that was asked, what are the practices being done in our hospital? We are an NABH pre-entry level hospital, and we have just last month we have applied for full NABH certification. There was some delay because of COVID only. We had been attempting for some time, but because of COVID it was delayed, and now since COVID is over we have applied, and the process is on. Most possibly in a few months we will be inspected and certified. So as regards the safety protocols that are required for in all areas of safety to the this patients as well as healthcare workers, we are taking up all the steps. regarding medication error, all the prescribed NABH protocols, right from prescription, indenting, then implementing medication, and then monitoring, all those points we are taking up and documenting very thoroughly. I'll come in detail with further discussion. Hopefully, I'll come in more detail about what are the things that are coming. But I would like to also relate a very personal experience about medication error, which has been a life lesson for me. And from that day, this error has not happened. It's a very personal story, but I will relate it because I hope this will bring some light into the importance of the situation. It was way back when I finished my internship after MBBS, and I was doing house job in a medical college. That was in Manipur. And at that time, insurgency was very much rife, very strong. So one day I was, I cannot say invited, I was called to attend a very big VIP insurgent for severe pain abdomen. So I went there and examined the patient and his story and everything, and I came to a fairly good diagnosis that it was a ureteric colic. And he was suffering with severe pain. So I said, injection, cyclopam will give immediate relief, and we should give that. So they arranged it to be brought. They sent some person, and that person brought that injection. In my enthusiasm to heal the patient from pain quickly and then move away from that surrounding very quickly, I gave it intravenous, hoping that it will relieve the patient of pain immediately. Just after I gave the cyclopam injection intravenous, he was sweating, but I was double sweating because he developed breathlessness, he became almost unconscious, his BP was going down, and it was a terrible, terrible experience for me. Fortunately, in about 1 hour, he recovered back without doing anything. I was just sitting by his side and he recovered. But imagine if he had succumbed to that. Imagine if that very, very, very VIP underground person had died that day. I wouldn't be sitting in front of you and talking about safety in medications in front of you. That was the situation. So what I'm trying to say is that the situations also guide us to take wrong decisions, which we should not allow. I knew that this is an IM injection, cyclopam is an IM injection, and it is written on that vial also. But somehow, on that moment, my decision was, because you can see I was stressed out in that situation where I was called in to attend that person. And I decided to give it IV. So these are things which should not happen, that's why. And from that day on, yes, definitely this particular problem has not occurred with me again. And that was a life lesson for me. So just to relate a story of a very difficult situation where wrong medication, wrong administration of medication happened. Thank you very much for patient here.
Thank you, sir, for your views. I mean, it was a very good example that sir told us regarding the aviation industry and the healthcare industry. Obviously, in the aviation industry, we have seen also pilots coming out from their areas or driving and coming out and going to toilet and all. But there is a technology, autopilot mode, right? So with that, I want to ask Ronit Bora, how can technology might help, or what help technology can make to ensure medication safety, especially in the hospital settings?
Thank you, Sudipto. Basically, management of medication, which is a very complex and multifaceted operation, which begins from prescription, then indenting, dispensing, administration, and finally monitoring. So there's a lots of chances are there for error, because multiple peoples are associated, and there is numerous steps which is associated and during the entire operations. There's a lots of evidence which we can see that implementation of information technology basically in management of medication has reduced or minimized the medication error to a very large extent. For example, if we talk about implementation physician order entry, or in short we can say prescription, electronic prescription. See, clinical decision making is also a very complex process where an individual needs undivided attention to memorize, recall, and synthesize huge amount of data to make a decision. So here, what the IT information technology do is like it basically exhibits or close the gaps between the knowing and doing. For example, a physician might know the history of a patient, like his food allergy or drugs allergy, or maybe drugs warning recall, or any other thing. But the thing is that during prescribing, he might not consider due to various reasons. So here the IT system comes into play, and it helps the physician with all the information, relevant information and data which the physician require to make a correct clinical decision, and thus preventing error. And moreover, we can see that most of the medication error happens while dispensing of medicine from the pharmacy. So here, one thing recently it has been adopted in most of the healthcare facility, like barcoding system, barcoding of medication while dispensing the medication. Barcoding has been implemented, due to which lots of dispensing error has been reduced. Moreover, during administration, medication administration, bedside barcoding systems are there. Now, what the nurses here have to do is like they have to scan the patient identification bracelet, and if any mismatch happen, promptly the systems alert that there is a mismatch of the identity of the patient, maybe, or the drugs or dose or route of the patient. Thus, ensuring the proper 5 rights of medication management, and from this the medication error is reduced. And lastly, what I would like to say that it has been seen that most of the inpatient medication error occurs during care transition period, like when the patient has been admitted or referred or transferred or discharged to other places. So what happens, the proper medication reconciliation list is required to prevent such type of error, where the IT system comes into play and it prevents all those types of error. And lastly, I would like to say that merely implementation of IT system will not be successful in preventing all those error. But if you if you want to minimize or reduce such type of error, what we have to do, there has to be proper systems or process. There has to be proper protocol which is needed to be implemented in any healthcare setup to minimize all such type of error, medicine error basically. And for example, formation of drugs therapeutic committee, or maybe there has to be a formulary identification of all those high-risk medicines, basically those narcotics and psychotropic drugs, look-alike and sound-alike drugs. There has to be a proper protocol by which we are implementing which we can minimize such type of medication error. And lastly, I would like to say that patient safety is like a cornerstone of any high-quality care. So everyone in a healthcare facility should work as a team. This is not only the responsibility of one department, maybe the nursing department or maybe the consultant or the technician, everybody in a healthcare facility has to work as a team to reduce patient harms, and which in turn will improve patient safety. Thank you.
Thank you, Ronit, for your views. I mean, now I will move on to my right, Dr. Soumar Dutta, Consultant Emergency Medicine of Narayana Super Specialty Hospital. Sir, I would like to ask you, like, since last 2 years, I mean, the world has been going through this pandemic of COVID. India's healthcare infrastructure, obviously, world's healthcare infrastructure was stressed, and so as well, we have seen the same here in India, especially during the second wave. Would like to ask you, like, during that period, or what you have seen, like, since the healthcare system infrastructure was stressed, manpower was very also low, many healthcare professionals were falling sick also. So chances of medication error could have happened more. It might have happened also, we may not know. So what all precautions you might have taken during in your hospital settings, as well as you, I would like to ask you if you can throw some light, because during the COVID times we have seen people running after some name of the medicine which they might have come across through their relatives, doctors, fellow doctors, कि ये मेडिसिन ले लो घर में बैठ के तो कोविड नहीं आएगा, ये वगैरह वगैरह. So how I would like you to throw some light on this, to what kind of experiences you had during this period. Thank you, sir.
Thank you for the question. Well, before coming to the question, I would like to say that I have been associated with NABH accredited hospital for 2014, and initially when I was that time the hospital that was working was accredited, lot of our work has almost double, triple. Not only for the working nurses, for doctors, the paramedics, the pharmacists, and every sector was stressed, because there were certain standards that has to be maintained, and documentation should be there that how you are maintaining those standards. Initially, we as doctors or nurses were very resilient, because we always tend to be in a comfort zone when we are working with a system for a long time, and it takes time for adaptation. So when NABH came, and as we are working with NABH now, the guidelines which we are seeing, not only for COVID, but for other patients also, lot of precautions are taken to reduce or minimize the patient harm. Right from the admission of the patient, the way we identify a patient, how to know that you are selecting the right patient, putting a unique ID number for a particular patient that will reduce the bias, and then the way that we are consulting the patient, the way we are writing the prescription, the way our prescription is being prescribed, the way the pharmacy used to dispense the drug, the way the drug is being administered and monitored following the administration. There are certain standard guidelines, and there is a separate chapter in the NABH for management of medication, where there are 11 standards, and some of them has some core elements that are statutory requirement. So even it's not my personal choice that I will follow or not follow, but it is a requirement by law. Otherwise, if we fail to prove if there is any negligence that has been proven, so the healthcare will be in trouble. So for that, there are a lot of documentations regarding patients management has to be there, and that has now gradually transformed from the paperwork to an electronic media, so that data are stored and can be replicated over time. During the COVID time when you started taking the patients in the hospital, there was a lot of apprehension, not only among the patient but also among the healthcare professionals, including me. Because we have seen so many people losing their lives irrespective of their age. We have seen young people, they have lost their lives. So all were apprehensive, and in a way we try to safeguard ourselves. And initially we had a problem in procuring the personal protective equipment. PPE, as you all know, there was a scarcity, and also the drugs. And when we usually take the patients, we divided our entire staffing into some other shift, and one shift when it gets over, we used to put them on quarantine. So we are working at almost 1/3 of the manpower, although the patient number was very high. So the requirement or the nurses patient ratio or the doctor is to patient ratio was very much altered. There is we couldn't get any other better solution for that at that time. During that phase, it was very difficult to prescribe medications because we are using a PPE kit, and it is very difficult to either enter in the system or because we have to wear gloves. Again, we take out the gloves, then take actually donning off, then prescribe. It is very difficult. So most of the orders were verbal. But actually in the standard practice, only for life-saving drugs, that only should be on verbal order. The rest of the medications which we use on routine should be in writing. So the nurses follow only written orders and not a verbal command, except for dire situations. And we have classified the drugs, that these are the drugs that we can order verbally, which the nurses will follow. But there is one thing, that the drug has to be written or documented within a time of frame of 24 hours. So that has to be followed. So during that COVID phase, mostly we were on certain new drugs because we never had an experience with those medications. There was scarcity even for some certain drugs. But what we have seen that we made a standard list of medications and categorized those patients, some requiring, say, based on symptoms, some having a very mild symptoms. These are the standard list of medications invariably we will be giving. And these are some people with a moderate severity, so these are the medications that we are giving. And this is a serious or severe form of disease where we will give a set medications. So we have classified the drugs according to patient severity so that we can we can ease our work by not writing, because there is standard prescription, just you have to tick and put your signature and date and time. So that's how we segregated the patients as per the severity and also the medications. Otherwise, many medications were mostly on verbal orders, which actually should not happen in a routine practice. But that was a very atypical type of thing that happened to us. So we did in our hospital in that way.
Thank you, sir. Were there any cases of medication error during that verbal order thing? Chances?
No, because the medications which were enlisted for COVID, luckily there was no high-risk medications. So we are fortunate enough, except for one drug, that is for blood thinner. So that again we have reserved it for the severe cases. So that way we could have segregated and make the thing safe for the patients. And luckily no misfortune happened to anyone.
Thank you, sir. I'll move on to my last panelist and one of the most important panelists, that is Ms. Purabi Das, in charge OT of State Cancer Institute, Guwahati Medical College, as well as the All Assam Nursing Graduate Association. Secretary. Ma'am, I would like to ask you, I mean, nursing professionals are what I have seen, we have seen actually as healthcare management professionals, we have been moving around across states, giving consultancy services in NABH implementation. We have seen nursing professionals to be one of the most dedicated professionals in the whole healthcare setups. Obviously, doctors and nurses are the pillars, but still, one of the most important key personnel nurses who spend most time with the patients. So in that case, how much pressure, or let's say how that pressure which the nursing professional handles, because there are multiple medicines which needs to be given to the various kind of patients who are there in the hospitals. And we all are aware with the handwriting of doctors, right? So one of the common complaint which we see when we go to hospitals, like the nurses always complain like doctor ने ये करके चला गया, ये क्या कौन करेगा, ये सब कुछ हम लोग को करना पड़ता है. So being a representative of that class of medical professional, I would like to ask you, I mean, how do you see that? How do you see your role in the medication safety part? And what have you flagged all your issues in the right forum or not?
A very good morning to all the respected and well-known panelists and all the organizing committee or organizing members of Integra Ventures, Mr. Sudipto, Mrs. Lipika, and all the audiences. So today I am grateful that I am able to speak on medication safety from the nurse's point of view. And before that, I would like to say that medication safety, the concept of medication safety and drug safety, it is not new, and it plays a major role in patient safety. And many rules, since ancient times, many rules, amendments, acts have been created to make sure that the drugs are safe and effective. And these regulations, furthermore, these regulations are continued to change to make sure that the drug should have positive benefit-risk balance. And the medications errors can be minimized if healthcare workers they take the precautionary measures. And in US, data from the US-based research studies shows that annually there are most of the medication errors in globally, 5% are deadly, and out of those 50% are preventable. So here, as audiences are, most of the audiences are from nursing background, yes or no? Yes. So in our nursing courses, in first year itself, in the fundamental of nursing, we have learned about the rights of medication. Yes? Yes. What? So tell me, can you recall those rights of medication? Okay. Those, basically it was 5 traditional drugs, but it has shifted to 10 or many more rights. So basically we can maintain the 10 rights of medication, like right patient, right drug, right route, right method, right dose, right patient education, right to refuse from both then the healthcare personnel and from the patient side, then right documentation, right assessment and right evaluation. Yes, those rights, if we maintain properly, then we can minimize the errors. And like there are many errors, medication errors can occur, like due to many causes. Like it can occur during preparation, during storage of medications, and also during the administration of medications. And it can the errors may occur due to like lack of knowledge. Yes, lack of knowledge of the nurses and other healthcare workers, and lack of checking the safety checklists, and also as I already has mentioned about the like verbal, it will also error may occur due to verbal orders or like poor handwriting. It is a most common causes which leads to medication errors. So one by one we'll discuss today like how we can prevent all these errors and how we can take the precautionary measures to prevent those errors. Like and also nurses are they have long duration of shifts, yes, and then they have very much like job satisfaction is not there due to less salary, then due to as sir has already mentioned, due to low nurse-patient ratio or other healthcare ratio is not maintained by the hospital and administrators. So there will be overburden of works. Okay, so these are there may be some disturbance from the other sources like attendance and all other co-workers. So these all may lead to the medication errors. And one more thing I have noticed that in many hospitals, the medical if any medication error occurs, the blame is given to the healthcare worker, particularly the person who is involving that. But it's the time for us or for the healthcare administrators to find out the root causes of the incident of medical error, or to find out the factors associated with these errors, rather than only blaming one person and terminating that person from the job is not the permanent solution. Other person will be recruited, he or she may do the same mistakes. Okay, if we're not able to find out the root causes or factors associated with it, then we'll not be able to prevent those medical errors. So it's time to shift the blaming practices, and rather we must focus on the find out the root causes of those medical errors. So I will, as I'm working in State Cancer Institute, I'm involving with the chemotherapeutic drugs and all. So here what when we first started our daycare unit, there was no biosafety cabinet. Like chemotherapy drugs itself a hazardous drug for the health workers as well as patients. Okay, so we must take some precautions while preparing, while administering all those hazardous like chemotherapeutic drugs. So when we started the daycare unit, there was no biosafety cabinet. We are preparing the medications in open room itself, and later on, when government sent us to the well-known reputed cancer institute, Tata Medical Hospital, there we have seen many things that we can implement here. So later on, our government has they have given us some biosafety cabinets, which is the most important things to start a daycare unit or chemotherapy unit. Like chemotherapeutic agents should be prepared under the biosafety cabinet only. And there are before what we did, one nurses or two nurses will divide the patients, will accordingly the patients what are the chemotherapy drugs he supposed to get, will first prepare it, label it, then we'll administer it. We'll just divide the patients. But what we observe in TMH, it is very standardized technique, and we have started here also to follow those standardized practice. First, to one nurses, if she handling the patients everything, starting from prescription to preparation of medication to administering the medication, during carrying out these activities, she might cause some errors. Okay, while preparing all those things or doing all these activities, she might get disturbances from other sources, and it may lead to the medication errors. So what we did, one nurses or two nurses, they will prepare only the drugs by assessing the patient's prescription, doses, everything they will calculate, and they will prepare the medication only under the biosafety cabinets. Then other 2 nurses will only level the medication by seeing the prescription. They will again reassess the prescription and they will level it. Then other 3-4 nurses, they will be in operating. They will give cannulas and all, and they will check the prescription again, and they will administer those chemotherapy drugs. So there will be, we can do the divide the works and do systematically, so we can prevent those medical errors. So this is a good example. We can implement it in our institute. And one more thing, some medication, we have known about the vaccines. Okay, the vaccines are some vaccines are heat sensitive vaccines, and manufacturing companies, they have some indicators on those vaccines, vaccine vial monitors. Have you heard about this? Yes. So by seeing the vaccines, the color of the vaccine vial monitor, that indicator, we can able to see whether the vaccines are exposed to heat or not, whether it is safe to administer or not. Okay, so it's also some manufacturer companies' responsibility to give some level or some direction, so that by seeing only we can able to identify whether it is safe or not to administer or not. And also hospital administrator, they can have there is a lack of communication between all the hospital staff. So if there will be effective interprofessional communication, we can share the problems, issues, and discuss the problems, then there will be less medication error. And there are many drugs, SR has already mentioned that many side effects will be there. We have to keep in mind those side effects, and as a health worker, we must take some more precautions in some special groups of populations, pregnant women, children, and elderly person. These are called as vulnerable population. So we must take precaution in this particular group of people. And all these things should be corrected by all the healthcare workers. And lack of education regarding the lack of knowledge regarding the drugs. So here I would like to say that while selecting the nurses, the hospital administration, they must look for the quality of the nurses. If whether she is specialized, or she has experience, or she has that education to work in that particular area or not. But many of our administrators, what they see, they will just try to manage the workers in a very low salary, and they just need the numbers, not the quality. Okay, and we the nurses, it's our responsibility to make administrator understand that the education of nurses is very much important. The specialized nurses who are masters in pediatric, psychiatric, they should be recruited in those areas, so that they can give better care and to the health setup. And with this, I will conclude my lecture.
Thank you, ma'am, for your views. We'll just open the session for questions from the audience. Anyone, all are free to ask questions if they want so. So you want
before the questions, I'll just highlight regarding a point about blaming that Ms. Purvidas was saying. In our hospital, we have implemented the non-punitive response. That is, there will be no punishment whatsoever for any error, which is not legally, it should not be like stabbing somebody. We cannot say that we will not punish that person. But if it is due to medication error or error in treatment, it will not be punished at all. This is right from induction. When the person comes into our hospital, we tell them this, that definitely you will not be removed from your job because you commit any error. But if you do not report it, then definitely you will be there will be problem. So this is a policy that we have followed, and it has the immediate response was that the number of reporting increased immediately, so that we could correct it in time and make it more safe for the patient. So I think if other hospitals are not practicing, I suggest that they do, because this is a good practice. People who are not afraid that their job is going to be lost, or they are going to be punished, or their salary will be cut, if they are not afraid, then they will tell what mistake they have created. So I think that is a good practice that we have started.
I would like to add something like as sir told, so like incident reporting, which we used to say in implementation of quality standards. A non-punitive action is good. Like if somebody does an error and by mistakenly, or by unintentionally, non-punitive action should be taken. So in future they will report if any incident occurs. But the thing is that there should be a policy, like if repeatedly the same person is performing the error, then there has to be some certain action should be taken against him. Maybe he is not competent, or maybe training is required for him. So I think incident reporting is okay, but repeated mistake or making mistake or error is also a problem or issue.
RCA and CAPA should be done for every incident. Then only the actual problem will come out, and then we can rectify.
So that's exactly very, very true. The error, if they report and we analyze, and then we do not go at the person, we go at the system. What is the system error that has happened? At which point of that administration error has happened, and try to correct that system, and we make sure that the person who has made that error is properly educated and advised, so that they don't make. If they make the same mistake again, then there is no way. Then we don't give another chance like that, because it is life-threatening. This is an error which can cause life-threatening. I'll give you one example of. This is a very practical example. I would like to audience to hear, because they are doing it. So one lady, one patient, the patient party came running to me one day in the OPD. Said the drip that the nurse is giving had fungus floating in it. And when I told the nurse, she immediately changed it and said, the nurse told me, please don't report this. The father of that boy who was being treated, he immediately came running to me, because the patient was my patient. You see, for the safety of the patient, or the father, the safety of the son is most important. It doesn't matter about the nurse's job or not. But she was afraid that if somebody reported that and she was caught, then her job will be in jeopardy. She will be removed from job. So I immediately ran to the patient. We did all the check, everything, and kept all steroids and everything ready if it is required. But fortunately, nothing happened, and it was good that the father detected it. But the system error that had happened, that is what we studied. Right from pharmacy onwards, to have reached the patient. This was about 20 years ago, when we were just beginning in our hospital. So the system error that has happened, that we corrected, and we did not do anything to that nurse, but we told her that this is the worst mistake that you have done. Because telling the patient not to tell the consultant, or not to tell the authority, is the worst thing, and that could kill the patient. You are the person who should first come and tell us that this problem has happened. This is what we have indicated. Thank you.
We would like to open the session for questions from the audience.
Yeah.
Kindly put up your hand. Yes, ma'am.
I'm
Yeah.
Dr. Kasturi. I'm the director here at Sankaradeva Nethralaya. After listening to you all, actually I came a little late. I do agree that what you have mentioned about the non-punitive action, especially what I believe that in every institution we should have a just culture, the safety culture, that is so important. And the most important, what sir has also mentioned, that the RCA. But I believe that RCA is more of a retrospective analysis. So whenever an incident happens, then we go for RCA, that is the root cause analysis. We try to delve deep into the causes then come to a solution, and we see that it is being prevented in further. But we should have something more prospective, like HSMEA. Like if we have something HFMEA, which is more prospective, where we can prevent the risks happening, that is what I think in the present generation all the hospitals should come up. Just citing an example, when I was doing my management program in Harvard, so there was a very nice incident where they're mentioning where a wrong leg was amputated. And then the RCA, I think it is available in Google, all of you can go through it. Then the RCA, they have found it, and they could find out actually this is a system error. So I don't think any nurse or any healthcare assistant doing something wrong, that it should be pinpointed to them. But I think we have to follow a bottom-up approach. But sometimes in such situation we have to do a top-down so that we improve the system. It is only with improving the system we can, prevent all this complication. And what Madam has already mentioned, I think yes, the pharmacovigilance is very important. So we should have a very effective pharmacovigilance so that all these complications can be prevented. But after being in this, hospital field for so many years, I still feel that a prospective, approach is better than, yes, retrospective is, because only when we do a retrospective analysis we get the data. And it is very interesting what Sir has already mentioned. In HMS, Harvard Medical School, they have once in 3 months a error reporting celebration. The more the error you report, that is being celebrated, because when we know the error, then only we know where to correct. If we don't report the error, we'll not be able to correct. So I think that error reporting, non-punitive, and a just culture, this is very much required, because there should not be any blame or shame game. We need to improve the system.
Thank you, madam. I'd just like to add on the proactive measures that we are taking. In our treatment chart and prescription, it is mandatory that all medication should be written in capital. There is no excuse for writing in small letters. Nobody can write in small letters. And there's no practice of writing per PO, BID, QID, all those we have stopped. It should be 4 times daily, it should be written 4 times daily, or 3 times daily, it should be written clearly. There's nothing like TID, BID, BDS, all those things we have stopped. So this is proactive way, and we have started the practice of read aloud before drawing medication. So whenever a nurse is made to draw an injection before giving, she should read aloud, so that somebody hears it. Whoever is the person who is next to her should hear that. So this also we have started as a proactive measure to prevent medication errors. Similarly, we have implemented lots of checklists in all different stages of patient management, especially those who are undergoing operation theatre. You're talking about amputated limb. So to prevent that, the WHO checklist, not only in the operation theatre, right from patient transfer from the ward itself through all the healthcare assistants, HCAs and all, they have the checklist to prevent all these errors. And definitely we have found very many situations where errors were prevented because of this checklist. So I think checklists are mandatory. Checking all the instruments, checking all the systems, and preparing a list and checking it on a daily basis. Every shift, checking all those systems is very important, I think, and that has saved us a lot.
Thank you, sir. Any more questions?
Here I would like to add one more important point. Like, yes, capital letters are, should be initiated, but if handwriting is very much poor, then rather we start like type prescription or type written order. That will be more effective for preventing those errors.
Yeah, there are certain hospitals who use, medical transcriptionists are also there. Yes, EMR is there, medical transcriptionist is also there who type the prescriptions also.
Yeah, basically right now most of the accreditation body like NMBH, if you say, or JCI, they are forcing, or they are putting much stress like to go for artificial intelligence or to implement IT system in a hospital. This is basically because doctors, they are very busy. Like there are lots of patients. If they are going to write in block letter, it is also a time consuming process. So instead of that, if IT is implemented, then it will be much more beneficial for that. And one more thing I like to add, as Sir told, like implementation of checklist. So the thing is that too much dependency on checklist is also it's not very good. Like for the namesake, as I'm saying, in the OT, most of the hospital right now, they are pre-entry level accredited NABS accredited hospital, which we have seen like they have already implemented those surgical safety checklists. But those checklists are being maintained for only for a namesake. There is a process like sign in, sign out, time in, time out. Like there is a process and protocol that all the doctors or all the team members have to introduce initially. Okay, there's some process. So, but for the namesake only, they are doing just sign it. The anesthesiologist will sign, and the circulating nurse, the scrub nurse will sign, the surgeon will sign. So the thing is that the implementation, proper implementation of these forms and formats is also very important. The checklist, basically the culture of implementing those standards, quality standards. The policies and documentation is okay. Every hospital, they have their own, those accredited hospital, but implementation for the same, it's very important. That's what I
PNT committee, pharmacology and therapeutic committee. It's a multidisciplinary committee that is formed with doctors and nurses and administrators and pharmacists. So like this committee makes certain checklists, and they also see that there is no duplication of work. If you go through the entire checklist, maybe in our hospital we have some 10 to 15 checklists. There are few parameters where there is duplication of the same work. So that consumes time. So that should not happen. So that's why the forms should be standardized and should be reviewed over time and time again.
Now, as I think all of you are from nursing background, so I will tell something which is very practical for us. Now we have a checklist. We have started from 1995 onwards. But what is my practical experience? Say before admitting the patient, one person check the patient to find out patient is fit for me. But ultimately in the operation theatre you detect the patient is unfit. Let us tell the truth. What I feel, the culture is very important. If the person is not responsible, that is telling from my personal experience. If the culture is not the culture of responsibility, then the things will not be correct. Artificial intelligence is one answer for that. And whenever we have said many issues, all human being has issues. But when we are in the working place, I think all issues should be set apart. Because we have to work for the benefit of the person. I may have many personal problems that I will sort out after my professional hours, not during the professional hours. The culture, what is there built up. First we have to question ourselves, this culture is 100% professional or not. Everybody can find out this culture is professional or not. I will go by the example, not by theory. One case I tell you that while I was doing the medicine intern, one person, when there is amoebic colitis, the treatment at that period of time in 78, it was administration of sulfa-guanidine enema. I do not know it is existing now or not. Sulfa-guanidine enema. One person is getting, then he one day complained me that they are giving the medicine through enema. I am feeling very much pain, etc. Then I checked the file. I was the intern at the time. I found that there is no instruction for that. Then what happened? This person, there is no fan, so he has changed the bed. And the nursing staff, they said bed number this enema. So they prepared and gave it. So that is the point, is that where is the problem we have to address it? She has said right person, right drug. it is there in the book, but we do not believe in transform into organizational culture, nothing is going to happen. I may have many problems again, I say, but when I am at the table, everything should be get up. And that sort of professional mentality we have to build up. We have to build that much of professional mentality. Now, I also like to apprise you one of my personal experience. Previously, after doing the retina surgery, I used to give everyone a diclonic injection. It is a non-steroidal anti-inflammatory agent. One lady, after going home, she told me that I have stopped my urination. I told, where is your home? Then I went there with my Maruti van. I took her to the medical college. She was under dialysis. That day I decided I will not give any extra medication which is not absolutely needed. And thereafter, till today, I have not given anybody a diclonic injection, but all people are painless with paracetamol. So that sort of insight is also needed from our mistake. Mistake will be there in everybody's hand. Nobody can say that I have not done any mistake. But to learn lesson and corrective action, that is the most important thing. SOP will be there, everything will be there, but we have to organize our culture. We have to culture ourselves to the profession. Sir has pointed out, aeroplane you get up without knowing the name of the pilot. Even we do not ask what is the aircraft. I tell all people of those who are working that you have to build a system like this. Patient will not ask who is the doctor, who is what is what. They have to believe in the system. What I want to say, take home message, system-based system. This person of the team member is good and this person more reliable. This concept must go to make our profession vibrant. System-based system. Any problem arises, system will correct it. For this system, what is the punitive action, non-punitive action, corrective action, everything has been described. So our take-home message should be from today onwards to eliminate the medical error. We should depend on system-based system. It include everything, error reporting, corrective action, all these things. So this is my suggestion to all of you, because after the end of the panel discussion, you have to carry home some message in your mind that be 100% professional, be system-based system administration. You can find out what is the correction to be done. Thank you.
Thank you, sir. With this, I would like to conclude this panel discussion which we had. I mean, already we are running out of time. We are running short of time actually. So I would like to thank all my fellow panelists here who have come for this discussion. Thank you all. And with this, I give it to Ms. Lipika to further carry out the session. Thank you.
Thank you all for the time and effort that you took. And the session was very insightful. And we had a very key takeaway points of culture, of practices, good practices in the organization, and artificial intelligence. Thank you all. Now we will move on to the first session of today's MDP on the topic Medication Reconciliation and Patient Safety by Dr. Shubrojyoti Bhowmick, who is the Clinical Director of Academics, Medical Quality and Clinical Research at Peerless Hospital and BK Roy Research Center, Kolkata. He has over 12 years of experience in the field of clinical research, pharmacovigilance and medication management in hospital. He has completed PG Diploma in Diabetes and Endocrinology from Royal College of Physicians, UK. He has a certification in clinical research, administration and project management from Stanford University, USA. So this session will be an online session And we'll be conducting it from Kolkata. We'll just start the session. We'll be having a tea break, a short tea break, and followed by the second session. And the remaining sessions will be offline sessions. Only this particular session will be an online because Dr. Bhowmick had some urgent meetings in Kolkata, so he could not travel to Guwahati.
I have another meeting to attend at 11:30, so if you would be able to put up my slides, that would really help me.
Yes, we'll do it.
Yeah. So at the outset, let me first thank my very dear friend Jyoti Das for inviting me here, and it's a pleasure to address you all on this World Patient Safety Day. And I first apologize for not being there in person, but I have few commitments in Calcutta and also in other parts of the country, so it was difficult for me to travel. But without wasting much time, let me speak on my topic, which has been allotted to me, is medication reconciliation and patient safety. I'm at PLS Hospital, Calcutta, and this is a 400-bedded hospital. It's an NABH accredited hospital. Next slide, please. So I want to declare that I have no conflict of interest. Next. So what is the definition of medication reconciliation? It is a process of identifying the most accurate list of all medications that the patient is taking, including its name, dose, route, and frequency. And once you have this list, you compare it with the physician list, especially when the physician makes that list during admission, transfer, and discharge order. Discharge order to avoid medication errors such as omissions, dosing errors, continuation of incorrect medication, and duplications. The very important thing is this comparing part. The second part, which is the actual reconciliation part of the process. Next, please. So why is medication reconciliation important? Medication reconciliation is important because WHO has asked us to focus on the medication reconciliation process. The WHO's I-5 project, which focuses on medication reconciliation, has an implementation guide, and I would request all the interested participants to look at this guide, which is available at the WHO website free of cost. And I had this experience of understanding this guide and implementing this guide when I was at WHO Geneva, working with Dr. Nilutparna, who is a world patient safety expert. And I can tell you that during this particular year focus, medication without harm, medication reconciliation is an important aspect. So the guide mentions that it is a formal process comparing patients' accurate and comprehensive medication history, which we also call the best possible medication history, with the medications prescribed during admission, transfer, and discharge. And the discrepancies which are found out are identified and brought to the attention of the healthcare team. Next slide. Why is this process so important? Because 60% of all medication errors, including in your hospitals, are happening during patient transfer, during patient admission, and during patient discharge. We are not aware of this, but we really have to look at this. These are errors which can occur when obtaining the patient's medication history. Because we usually take the history of the clinical diagnosis or the clinical features, but medication history taking is still very, very weak across the globe, including in India. And this errors leads to improper medication reconciliation. Next, please. So the medication reconciliation forms a very important part of the WHO's third patient safety challenge, which is a medication without harm. And there's a current challenge which is on from 2017. And this guide, which I was talking about, please have a look at the WHO website, Medication Safety in Transition of Care, a wonderful document. And the rest of my presentation is actually a summary of this document. Next slide, please. So give another click, please. So where do we perform medication reconciliation? we perform wherever the patient is changing from transition. So from home, patient is moving into emergency, there the drug might not be, the medication that the patient is taking might not be properly captured. When the patient is moving from emergency to ICU, there is a chance of missing it. When the patient is moving from ICU to patient being stabilized and is moving to patient general wards, there is another chance where you can miss medications. And finally, when the patient is moving into either rehab clinics or back home during discharge, huge chances of missing medications. Next chance, please. Next slide, please. So the WHO patient safety report talks about statistics, and they are glaring. To an extent of 50 to 60% of all medications are missed across the globe in community, in hospital admission. And if you look at the statistics, 62% of the patients had at least one unintentional medication discrepancy at transfer in between hospital. And this is data which is coming in primarily from the Western countries. In the developing countries, the situation might be even bad. Next slide, please. So the transition of care is a major weak point, and you at your hospital have to increase the vigilance and strength at transition of care. And if you don't do it, then these medication discrepancies will arise, resulting in improper reconciliation. Next slide, please. Next slide, please. Please give clicks. Yes. So an up-to-date medication history is obtained during the reconciliation process. It's a structured, formal process. And considering the complexity of implementing it, I would request all my participants to implement it in a phase-wise manner. Medication reconciliation at the admission. This is the weakest area. Please start the medication reconciliation process at the admission. This can be a first place where you can start it at your hospital. Next slide, please. Yes, please give clicks because I had animations here. Please keep clicking. Yes. So I think medication reconciliation should be integrated into the process, and very important that it is not the responsibility of only the doctors to do it. It is not only the responsibility of the nurses, it's a shared responsibility, just like patient safety. As you had the last discussion that it's a shared responsibility, medication reconciliation is a shared responsibility of doctors, nurses, pharmacists, and very importantly, the patient family and the patient has to be involved. And all the staff responsible has to be trained, and there has to be a structured SOP or standard operating procedures on how to obtain best possible medication history within 24 hours of admission of the patient. Next slide, please. So the best possible medication history, or the BPMH as they say, should capture all prescribed medication when the patient is instructed to take all non-prescribed medication, all non-prescribed over-the-counter medication, and all recreational medication. And I tell you that in our country, especially with my hospital, I've seen that many patients are taking homeopathic medications which they are not telling us. Sometimes drug interactions are happening at that level as well. So we need to monitor, and we need to also take the history properly, because we might miss these important medications which can have an implication and on the outcome of the patient. Next slide, please. So the possible sources of information for the best possible medication history according to WHO is the patient. You interview the patient. You also interview the family. You can look at the medication vials and lists. Sometimes patients bring the medication strips. They bring the vials. In the Western countries, the WHO has found that family physician interview or family physician discussion is essential and is helpful for medication reconciliation process. Patients can bring medication lists, and in electronic records, I think for hospitals like Shankar Nethralaya, which practice electronic record, medication reconciliation should not be a big problem, because you can always look at the medication reconciliation, the previous medication records in your electronic records. Next slide, please. So whatever might be the source, please complete your medication reconciliation process by obtaining the BPMH within 24 hours of admission of the patient into the hospital. Next slide, please. What is the staff role and documentation? Extremely important role of clinical pharmacists. And I would say that every hospital should have a clinical pharmacist who should be involved in the medication reconciliation process. And if the clinical pharmacist is not available, then a junior doctor or a nurse or a technician should be trained so that they can be involved in the medication reconciliation process. It has to be documented and kept in the medical records so that every healthcare professional can access it. Next slide, please. For how to implement medication reconciliation framework. So these are the guidelines in WHO. Number one, get organizational support. Nothing in quality and patient safety moves if the senior leadership does not believe in it. We need to form a team. We need to develop a work plan. We need to process the current we need to map the current process. We need to have a measurement strategy. Next slide, please. We need to define the problem and collect data and pilot testing. Again and again, I'm telling you, don't try to do it for the entire hospital. It's going to be difficult. And evaluate improvements, however small it might be, and then eventually spread it throughout the organization. Next slide, please. So the management is the most important decision maker, and if the management wants proper medication reconciliation, it will form a team, and I would say a structured SOP has to be in place, which needs to be implemented with the help of management support. Next slide, please. There has to be a team, and the team should consist of doctors, nurses, as well as pharmacologists. The clinical pharmacologist should lead the team, being the subject matter expert, and the ongoing communication with the team is of supreme importance. We need to develop a work plan. The work plan has to define timelines and responsibilities. So if we decide that in the emergency of our hospital, we are going to look at the medications coming in for acute congestive glaucoma, and we just focus on those patients, whether they have been reconciled properly or not, and then eventually over 1 month time, we decide that we will have to achieve a certain level, and we see with re-audit if that has been done or not. That way, with slow steps, we will be able to implement it with different domains. I'm giving the ophthalmology example, but it can be other examples in other specialty. Never try to go for the entire focus area at one go. And the frontline staff has to be engaged. The frontline doctor, the nurse, the optometrists, they have to be involved. If you don't involve them, then let me tell you, ladies and gentlemen, there'll be resistance and you can't implement the medication reconciliation process. Next slide, please. We need to map the current process in a very simple flow diagram, which will, in many of the hospitals, there'll be no structure at that point of time. That is also important information, and eventually develop a flow diagram on what we want to do and how we want to implement the medication reconciliation process. Next slide, please. So we need to define a problem, as I gave you the example in case of your emergency of ophthalmology unit. Look at acute congestive glaucoma patient. What are the patients, these patients, what medications they are receiving, how it is being reconciled, and this has to be time specific and measurable, and they have to, so it could be like, we can't say that for 6 months we are going to do it. It has to be very time specific and in a measurable manner. And the SOP has to be implemented with the help of the staff as well as of the quality professionals, because this is extremely important. And whatever there is, it's the experience, good or bad. With bad experience, if there are resistance, we need to go back and change the SOP accordingly. Next slide, please. So there are 3 indicators which the WHO has defined to measure medication reconciliation process has been done properly or not. Number 1 is the percentage of patients who have undergone proper medication reconciliation within 24 hours of decision to admit the patient. Number 2 is the mean number of outstanding unintentional medication discrepancy per patient. And number 3 is the percentage of patients with at least one outstanding unintentional discrepancies. I'm describing it in the next slide. Next slide, please. So this is the most important indicator, is that you define the number of eligible patients receiving medication reconciliation within 24 hours of admission divided by the total number of eligible patients into 100. So in new hospitals or hospitals who don't have medication reconciliation, their percentage is going to be very, very low. Don't get disheartened with this, because eventually with small steps, you will make the bigger step. Next slide, please. The mean number of outstanding unintentional medication discrepancy per patient is the number of outstanding unintentional discrepancies divided by the number of eligible patients. Now, ladies and gentlemen, please note that unintentional discrepancy is mentioned. None of the healthcare workers wants to do error. Error is defined, we are forced to do error because if we have a faulty system. So never ever believe that if a nurse is not able to reconcile or a doctor is not able to reconcile, it is their fault. It is the fault of the system. Maybe they require extra hands. Maybe they require more training and education. So the WHO has defined this as an unintentional discrepancy. Next. And the other one is the percentage of patients with at least one outstanding unintentional discrepancies. And this is the minimum sample size here has been defined by WHO as 30. Next slide, please. So to summarize my presentation, I would say medication reconciliation is an essential component of medication safety and medication safety. There are discrepancies which happen when medication are prescribed to patients and what patients take. We need to correct it. We need to improve. We need to improve the reconciliation process. Kindly go back, please. Yeah. No, I would say please go back one slide. Thank you. Yeah. One more click, please. So medication reconciliation can help to reduce these discrepancies and improve the patient outcome. That is what all the healthcare workers require. Next slide, please. Next slide, please. Yeah. I would say the outcomes are associated with medication discrepancies can be costly, because we have seen that these errors are costly. And according to the latest WHO report, $42 billion are spent in prevention of medication errors. If we can save these dollars, it can come handy for other public health programs in the world. An organizational structure is required, led by a clinical pharmacologist, to support medication reconciliation activities. Support of the management is paramount, and implementation of medication reconciliation is always in a phased manner, always in a pilot phase manner. Never do it in a holistic manner, and monitoring is required with specific quality indicators which WHO has prescribed. Next slide, please. To conclude, I would say that please remember on this World Patient Safety Day that there are no biologically safe drugs. There are only safe physicians, safe nurses, and safe pharmacists. Please, please, please aspire to become one of them. Next slide. These are my references, and I've already sent the presentation to Lipika. You can always have a look at the presentation. Next slide, please. Thank you very much. That's my hospital. And if there are any questions, I'm more than happy to take the questions.
Thank you, Doctor, for such a stimulating speech and for accepting our invitation at a short notice. And also, in spite of your busy schedule, you have taken out time for our participants. Any questions, participants? Thank you, Doctor.
Thank you, everyone. Thank you to Jyoti as well. So please give my regards to him. Thank you, Lipika.
Yeah, thank you. So before we proceed to our second session, let us have a tea break. And the tea is served just outside the auditorium, and we'll meet at 11:55 because the next session by Dr. Nilutparna Deori will start exactly at 12 p.m. Thank you. AIOS. She is one of the most skilled and trusted pediatric ophthalmologists in Northeast India. We welcome you, Dr. Deori, onto the stage. I would request Ms. Dipshika Roy to felicitate Dr. Deori.
Good morning, everyone. At the very outset, on behalf of Sri Sankaradeva Nethralaya, I would like to welcome you all to this institute. And I'm extremely honored and humbled to Integra Ventures for giving me this opportunity to speak on medication errors and preventive measures in ophthalmology. I do not have any financial interest in this presentation. So let me begin by citing the United States National Coordinating Council for Medication Error Reporting and Prevention. It states that any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professionals, patient and consumer. Such events may be related either to the professional practice, healthcare products, the procedures and systems, including prescribing, order communication, product labeling, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. In the early hours of today's morning, in the early sessions, we have already highlighted few of the important problems that we face while prescribing the medication, while dispensing, and even while administering. So these are some of the points that will be highlighted again in this, but in the view of ophthalmology. So we all know that medicine prescription is a complex procedure and error can occur at any point of time, starting from the prescription to the installation of the drops to the correct patient to the correct eye. So in one of the studies in UK, they showed that 7% of the prescriptions contained errors. This was a study done by Lewis et al. But there was one point that was highlighted. It was highlighted that even the more experienced doctors or the consultants tend to make just the same errors as their junior consultants. So where do we stand today? And where do we need to rectify ourselves? So some of the risk factors can be addressed in this situation. So I will speak about some of the factors that can lead to increased risk of medical errors. Now the factors which may be associated with healthcare professionals are lack of therapeutic training, both in terms of the consultants as well as the primary care givers. Inadequate drug knowledge and experience, this pertains to doctors, the pharmacists and the nurses. Inadequate knowledge of the patient himself, inadequate perception of the risk that is associated with the prescription of the drug or the side effects of the drug, overworked or fatigued healthcare professionals where the working hours extends beyond 12 to 14 hours. Physical and emotional health issues, which is where you are always preoccupied with your emotional issues or some physical health issues where you cannot move around properly. So this needs to be addressed before you attend to a patient. Poor communication between healthcare professionals and the patients, where you feel that the patient understands what you are speaking or what you are relating to them. So it is important that you speak in the language that the patient best understands, and then after your counseling you have to make sure that the patient has actually understood what you have explained to the patient. Factors associated with the patients are basically patient characteristics, either the personality of the patient, the literacy level of the patient, and sometimes the language barrier. Complexity of the clinical case, including multiple health conditions where polypharmacy may be required, and the high-risk medications that needs to be prescribed orally, both for the systemic disease of the patient as well as for ocular complications. The factors which are associated with the work environment are workload and time pressures, distractions and interruptions, especially while attending to the patients when you are on the mobile phone. That is not actually advisable. Lack of standardized protocols and procedures. The SOP has been always given prime importance. SOP, Sir has also explained that the aircraft that you fly in, actually it follows the standard operating procedure for which you do not feel the fright of getting into the flight. So that is the standard operating procedure or the standard operating protocol. This differs for the hospital-based as well as the non-hospital-based institutes. So whatever protocols or procedures are in place are to be followed by all. Insufficient resources, issues with physical work environment like the lighting conditions, the temperature and the ventilation. Factors which may be associated with the medicines or naming of the medicines. Particularly, this is a problem when they are look-alike or sound-alike medicines, which causes a lot of problem while dispensing as well as administering these medicines. So you need to have a proper knowledge about the formulary of the medicines, the labeling and the packaging. Usually the manufacturing unit or the companies, sometimes the same company issues products which look similar all the while, and then you tend to actually prescribe a medicine which was not supposed to be given to the patient. So that is a wrong prescription which occurred because of a look-alike medicine. Factors which may be associated with the tasks are repetitive systems for ordering, processing and authorization, basically in the administration part of the staff who is responsible in the hospital or the primary care workers who are working in the periphery. Patient monitoring, which is dependent on the practice, the patient, other healthcare settings and the prescriber. Factors which may be associated with computerized information systems is because as we are moving to a digital platform, we are using the EMR system, that is the electronic medical records maintenance. So here the difficulty that arises is that you need to train yourself towards this electronic media, how to use the computer, how to use the systems that are present and how to integrate it in your daily life. Because it takes a lot of time actually to get accustomed to such kind of electronic software use, and that can be actually modified according to your uses. For example, a EMR here that we use, that is the electronic media record that we use, may not be suitable for a small scale institute or maybe a private practitioner. So that has to be modulated. What needs to be remembered is that the drugs that you are prescribing or the patient details that you are entering should be well documented in the in the EMR. So that is basically the training protocol. So there may be difficult processes for generating first prescription. This usually happens in most of the cases. Difficult processes for generating correct repeat prescription, for which you need to form a template, and you can use the template for that particular disease. But it needs to be modulated whether you are using it for an adult patient or for a pediatric purpose. Lack of accuracy of patient records. So well-documented records are important for a follow-up of the patients, especially in case of ophthalmology when you have a patient who is having, for example, glaucoma. The glaucoma patients needs a lifelong management. So if you do not have a well-documented record of the patient, then you fail to understand how the patient has progressed through the years for that particular disease. Inadequate design that allows for human error. As I have already pointed out, that the same software may be curated for individual hospitals or individual persons for their practice. So you do not take up a system which will actually cause more errors than benefit to your patients. Primary and secondary care interface. This is actually a communication between the primary and the secondary healthcare workers, or also the tertiary institutes where you need to refer these patients for their management. You need to have a coordination and a holistic approach towards patient care. So the limited quality of communication is what leads to medication errors, and the justification of secondary care recommendations. That is, if you are writing something, you need to be very legible of what you are actually, what actually you want the patient to be given. For example, prescribing the drug in correct doses, the correct strength to the proper eye and to the proper patient. So some of the risk management as an overall view, you can see in ophthalmic subspecialties, as we all know right now we have, and what I have written here is the related fields. Related fields is that our ophthalmological problems do not come as an individual problem, but sometimes they are related to their other systemic associations or maybe other genetic conditions which needs to be addressed in a multi-approach system where you require the help of your colleagues from neuro-ophthalmology or maybe neurosurgery or neurology, or maybe your pediatricians or your geneticist, which needs to be same. So medication-related errors are mostly because the omission errors drug interactions, the dosing errors, and sometimes it is also missed out in patients, basically women who are nursing or are pregnant. So the drugs that we need to use, they are categorized according to the pregnancy state of the patients. For example, the glaucoma medications are also categorized accordingly, and some of the other medications that we use. So that needs to be kept in mind, which drug needs to be given in which patients and in which trimester. So for example, let us see another surgery-related errors also, because post-surgical medication errors also seem to be very frequent, especially relating to the wrong eye and relating to the wrong medication that has been prescribed. The most common surgery that is performed in ophthalmology is cataract surgery. So in cataract surgery, if you have to provide a consent document to the patient relating to the consent that he is giving his full consent to undergo the surgery, as well as to the institute for the risk and complications associated with it. So the most dreaded complication that we encounter post-surgery is endophthalmitis. So pre-operative counseling, if the patient has not been advised regarding all the risks and complications associated with the surgery, and following the surgery, if the medications have not been explained well to the patient, both in the language that is written in English, that is written in the document, or in the language that the patient best understands, is then you end up with some medication errors at the post-operative stage. So here it is very important that you really give a good pre and post-operative counseling to the patients. Now in cornea-related complications, we usually go for this transplant surgeries like penetrating keratoplasty, or also like lamellar keratoplasties. These surgeries also require some amount of preoperative counseling, and why the surgery has been performed, whether it is therapeutic or whether it has been performed for other optical purposes. So those instructions is a must in any of the surgical procedures. Now suturing, while we perform these surgeries, we give sutures to the corneal tissue. Now you might feel that a small suture might not create any problem for the patient except for the irritation, but there are instances where the suture removal itself may cause endophthalmitis in these patients. So it is very important that you tell the patients that a suture has been applied and we are going to remove it when and when required. And contact lens users. Many of us nowadays suffer from refractive errors, and because we do not like the look of the glasses on our faces, we tend to move on to contact lenses. So contact lens wear is something which is taken sometimes very lightly, especially for cosmetic purposes. And they fail to maintain the ocular health hygiene, which results in keratitis or infection of the cornea. So these are some of the situations where before prescribing, the patient characteristics also needs to be taken into account. The next one is the refractive surgery. Similar to, as I have explained, like the glasses, if you are wearing thick glasses, you tend to remove your glasses when you become an adult by the age of 19 to 21 years. So in that instance, if the statistics of the surgical procedure has not been explained to the patient beforehand, the patient might have some unrealistic expectations following the surgery. So you need to be very, very careful about what you speak and how you have documented it. And the most important one is the emergencies. Now, when you are dealing with an emergency patient, you need to understand that the patient is always accompanied by the attendant. You have to make sure that the attendant that is accompanying the patient is actually the first relative of the patient, or maybe a parent, or basically a first degree relative. Otherwise, what happens if a neighbor comes or something, by the time you treat the patient, there is more of a ruckus that is created and leads to some other medical legal problems rather than a medication error in this situation. So here a physician-patient relationship is very important, because the patient will trust on you for his ocular condition, and he believes that you will cure him of his problem. So you need to give him the entire picture, what he is suffering from, what you can do best to the best of your knowledge, and what will be the visual prognosis. Basically, when in an emergency patient, you need to remember three things. It is the life that is more important, so a multi-approach is very important, multi-speciality approach. Then comes your globe restoration, and finally the sight. So these things should be explained, documented, and you have to make sure that the patient and the attendant understands to it. So it is the responsibility of the attending person along with his team who are in the ER, and a communication which is very reliable, and which sometimes in medical legal cases you need to go to the court to provide all these documentations. Examination in the form which is best for the patient at that particular time, maybe with a torchlight examination, or whichever is best performed, whether it's slit lamp examination or an indirect ophthalmology, is to be kept in mind. Here, one of the most important things that we try to maintain is the visual acuity of the patient at presentation needs to be documented. Similarly, in other situations like neuro-ophthalmology, a patient might present to you with a symptom of headache, which is a very common symptom, but you need to understand that this symptom may arise from something which is related to the eye and maybe the optic nerve. So you have to explain to the patient that the patient might need to undergo some investigations and may require a neurology consultation. In pediatric patients, this is very important, I should say, because an unaccompanied minor is, or a minor who is accompanied by, not by the parents but somebody else, you should not entertain the attendant in the sense that you are explaining the entire procedure to the attendant who is not a parent of the child, and then later on if you are going through a surgical procedure and then the attendant comes to you and says that, oh, I was not here last time you told me, you told about the child, but this time it is, I am actually the parent, last time it was the neighbor. So this should not be done. This you have to understand. Second point, the most common drop that we use for the children in the OPD for their refractive error is the cycloplegics. The anticholinergic drugs like atropine. This drug is used both for dilatation and to see the refractive status of the child post-dilatation, as well as it is used in therapeutic doses, which is almost 1/100 of the concentration. However, this drug contains your side effects like fever, drowsiness, and even a dry mouth, and the child may collapse even in the OPD. So you need to be very careful regarding the uses of these medications. And I have already told you regarding refractive surgery, and glaucoma is another situation where you need to act very fast. And since it is a child that you will be operating even at the stage of 21 days, you need to keep the expectations of the parents and the need for stringent follow-up post-surgery. So let us come to some other things like a prescribing error. I do not have any affiliation to this company, but I would just like to show you these two photographs where you see that these are two look-alike drugs. Both look alike. For a person who is not literate in the formulary of the drug, he will feel that the two drugs are similar and can be applied. But you see that this medicine is actually an atropine sulfate and anticholinergic, and this is only a sodium hyaluronate which is used as a lubricant. The effects of both the drugs are totally opposite. This is a lubricating eye drop that is given for the comfort of the ocular surface, and this is an anticholinergic that is used therapeutically for the control of myopia. Myopia is a condition where you have minus power in the glasses, and you need to continue these medications for at least a year before you taper them off. So this may create a lot of problems. So there are some other drugs also which may sound similar, like for an orocaine, oromide. So when you are speaking, you should be very, very specific about what you want and what you are doing. So this becomes a challenge for a pharmacist as well as the nurses when they are keeping this or storing these medications. So you need to have a different labels or different stockpile where you are actually keeping this look-alike and sound-alike medications differently. Otherwise, in your hurry or co-managing this customers or the consumers, you might tend to give a medication which was actually not prescribed for the patient. So wrong patient details may lead to confusion, delay in the treatment. Eye medication prescribed which are not locally available. For example, antimicrobials. You do not prescribe medications which are not locally available, because that will cause more problem to the patient than any benefit. Now, if you feel that a patient is from a different locality or a far-off region, you need to understand that the patient might require a refill. So looking at the expiry date of the bottle, and then you should dispense the medicine to this patient so that if the bottle gets over, he can use the next bottle before he comes back to you. And and you have this thing that is the preserved and preservative-free formulations in eye drops. The most commonly used preservative that in eye drops is your benzalkonium chloride. Now, benzalkonium chloride also has this effect of damaging the ocular surface. So, if the epithelium is abraded, the penetration is more, and also it increases the shelf life of the drug. So, if you feel that the patient requires a preservative-free medication and you have prescribed a preservative medication with a preservative, then it will have a different effect on the ocular surface. Second is the wrong strength and the wrong dose. Definitely this is something that you need to understand, especially from the consultant or from the prescriber's point of view, that you need to mention exactly what you are prescribing. The strength of, for example, this atropine sulfate comes in the form of 0.1 and now it is coming at 0.5. And also you have the 1%. The 1% has got drastic effect compared to the 0.01%. So you really need to be careful where you are prescribing. Also, if you are prescribing these drops to the patients, which age? So the knowledge about the drugs as well as the patient is important in prescribing the correct strength and the doses of the medications. Now the last, the patient is not advised about the expiry date of the product. You will see in a drug the expiry date is written like today is 2022, the expiry date is written to 24. That does not mean that the drug can be opened today and can be used after 1 year or maybe a month. So the correct statement is patients should be advised about the expiry date of the product once it has been opened. So once you have opened the drug should, or the eye drops should be used only for that month, particularly only 1 month. After that you discard the medicine and you use a new bottle. So you have it in your home, so you use it again is not the correct recommendation that you should give. Now eye drops, eye gels and eye ointments have shorter life, so do not reuse them over periods of time. You buy a new one, you apply the new one. The storage also should be kept in mind, the information regarding the storage. Some drugs require to be stored in cool temperatures, like for example the door of a refrigerator at 18 degrees Celsius. It is already mentioned sometimes in the leaflets, so you should be aware of the information regarding the drug, where it should be stored, how it should be used. So that is one. And definitely wrong eye. Wrong eye is one thing that we cannot actually overlook at all. So how to avoid these prescribing errors? Now you see, this is one chart that I have taken from one of the articles by Oslin et al., where you see the name of the hospital with the communication number. The patient details, his name, age, his address has been noted down so that you can talk to the patient later on if you require him back to your OPD or to the OR. The treatment that has been provided is in the formulary that is given under the guidelines of the national or the international formulations. So if you're providing a drug like a latanoprost, you write it in the generic name, how much it contains, 50 micrograms per ml. Is it an ophthalmic solution or is it a drop which contains, like for example, Predford, it contains the sediments. So you need to be careful about telling the patient that what formulation are you using, or is it provided in a bottle, or how is it provided. And the signatory, like take 1 drop in each eye at night. So it defines that you need to put only 1 drop in both the eyes and at night time only. Here you can also mention, like for example in glaucoma drugs we mentioned 7 a.m., 7 p.m. or likewise accordingly. And up to what duration the patient needs to use. So these instructions are to be given very legibly in the prescription. The prescriber's details, or the person who is prescribing, his registration number, the date of the prescription and the signature. And finally the pharmacy dispensing details are also to be mentioned. The pharmacy which has actually dispensed the medication, starting from the name of the pharmacy, the dispenser, the date, pharmacy and the stamp. Now, check for any patient allergies before prescribing any medications. It might not be known to you, but you write a line that if you're allergic to the medication, kindly stop it immediately and report back. So that those things should be also explained to the patient. Use the generic name I have already advised, and kindly avoid the abbreviations. Now, dispensing and administering medicines. For dispensing, I have already pointed out that the pharmacists are the final point of contact in the community before patients take their medicines home. And for administering, it is the nurses who are the final point of contact before the patients are administered. But this is in the hospital setting. But if you are in the home setting, even the nurses here help them to understand about the administration, the route of the drug that has to be administered. In ophthalmology, sometimes we need to block the lacrimal area that is near your eye before after instilling the drops, so that it does not go into the nasolacrimal sac and cause more systemic absorption. So you need to explain to the patient how the drops should be put, that it should not, the tip of the dropper, that is the bottle, should not touch your eyelashes. You should take a tissue paper before instilling the drops, so that the extra or the excess drop that is there, when it flows down, you need to wipe it down the cheek. And also you need to understand, you need to tell them that the tip of your fingers or any part of your hand should not be touching the tip of your eye drop, because you don't want any retro infection going in and using the same drug. The hygiene of the bottle should also be maintained. Consider the benefits of written information. If you have leaflets in your hospital, kindly give out the leaflets regarding the medicine prescription, and this will help in patient understanding. So administering topical eye drops in a hospital setting, we also keep eye drops which we use for our daily use in the OPD and in the OR. These eye drops should be discarded after 7 days and replaced if the treatment continues. And in a non-hospital setting, it is every 28 days or as directed by the information sheet. So as we are moving to a digital platform, we are prescribing more and more electronic prescriptions. So although electronic prescriptions provide a clinical decision support, it is important that you understand that for each patient it is individualized. So in the electronic data, the highlight or the pop-up should come out regarding the risk of any risk, high risk quality for the patient, or if the patient is allergic to any medication. So therefore, a holistic approach to the patient to exercise good clinical judgment is important, whether you are writing a paper-based prescription or an electronic prescription. Now this is an example of our institute. I'm just showing you. This is a medicine prescription that we give out in the OR. So you see the hospital EMR records show the institute's name, the communication area, the identification number of the patient, the name, the age, and the prescription that we have advised, like which eye, that is the both eyes, what is the generic name of the drug, how it should be given, for how many days, how is it tapered, and any general advice that is given to the patient. And finally, the signature with the name of the doctor. So this has been, we have omitted for the presentation. Similar, this is another discharge summary for post-operative instructions, where the diagnosis along with the procedure that has been performed, and where the drug has to be administered, and the follow-up, and followed by similar signature of the prescriber. So the SOP or the standard operating protocol should follow the flow chart, where the patient's condition is deemed to require a drug, the correct drug is then selected, prescription is completed correctly, it is prescribed, then it is prescribed correctly, whether the route of administration, the dose, and the interval that it should be given, drug is dispensed correctly by the pharmacy, and then it is taken as per instruction from the nursing station or from the OPD. So once you have a medication error or any other error in a hospital institute, so you need to go to the root cause analysis, determine what has happened and why it has happened, figure out what to do to reduce the likelihood that it will happen again. So it follows the 5 points, where you define the problem, then you collect the data regarding why the problem had occurred, identify all the possible causal factors, and then identify the root cause among all these problems, and then recommend and implement the solution. This is a team-based approach that needs to be integrated in every institute you are working at, or even if you are working in the primary setup, this also requires a team-based approach. So in conclusion, you follow a process of checking and counter-checking before prescribing, the dispensing and administering the drug, which can be taken care of if the prescription is wrong, can be taken care of at the pharmacist level while dispensing, and even if it was missed at that point of time, can be taken care of when it was administered by the nursing staff. Education regarding drug administration, I should not say more, because continued medical education for evidence-based practice is very, very important. Communication gap is what creates a lot of problem in the society, and a strict adherence to SOP. So I would like to acknowledge my students who have helped me in this presentation, Dr. Anusha and Dr. Rutusha. Thank you once again for your patient hearing, and welcome to Sri Sankaradeva Nethralaya.
Thank you, Dr. Deori, for such an incredible, informative and interesting presentation. Thank you. Moving on to the third session is on medication safety in pediatrics by Dr. Partha Pratim Bora, consultant pediatrics of Pratiksha Hospital, Guwahati. He is trained in pediatric pulmonology and bronchoscopy, diploma in pediatric sleep medicine, and national coordinator for the cough module. We'd like to request Ms. Nabanita Das to felicitate Dr. Borah.
Good afternoon, everyone. First of all, I'd like to thank the Integra Ventures for giving us this opportunity on the Medication Safety Day. And thanks for the wonderful introduction. We'll be talking about medication safety in pediatrics, basically. And as you all know, pediatrics is a wide range, basically. We have a newborn, a neonate, it becomes a toddler, an infant, an adolescent, and then it becomes an adult. And nowadays, even the toddlers or even the adolescent, they are almost like adults. So we have different age formulations, different drug formulations, and all these drugs are not just tablets or capsules. We have to calculate the doses, and we have to deliver the medications accordingly. So why children at risk? We know that these are drug doses are calculated based on patient's weight, age, and of course many drugs are even prescribed based on body surface area. So whenever we are dealing with a pediatric patient, we always need to carry a calculator. It's not just you can write a prescription. For every patient you need to have a age and weight. So and this again changes, especially when you're prescribing an anti-epileptic drug, a drug which is for a long term. Every time a child comes, you have to calculate the weight, you have to take the present weight, and you have to recalculate the dose. Otherwise, the drugs will not be effective. Even especially in neonates also. Whenever a child is admitted into the neonatal intensive care unit, every day you have to calculate the IV fluid. We calculate the IV fluid based on not in days but in hours. We calculate the fluid in first 12 hours, then again in the next 12 hours based on the electrolytes imbalance of the child. So there are inadequate informations. The many drugs which are not available in proper doses, and there are fewer internal reserves to buffer any medication error which may occur. So what is considered a medication error? It is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient or consumer. So as Dr. Deori has already elaborated, there are different types of medication error that can occur at the level of prescribing, omission, wrong time, it could be unauthorized drug, improper use, wrong dose prescription and wrong dose preparation, and administration errors include the incorrect route of administration, giving the drug to the wrong patient, extra dose and wrong rate. Where I would like to emphasize regarding the vaccinations that we do, especially in the OPD practices. Most often nowadays the oral vaccines that come, they comes in syringes. And it has happened many a times. Few months back there was a big problem in Dibrugarh area especially. Oral medication came in syringe, the sister injected it. And because of which there was a big ruckus in the hospital setup, and again all has to come up and then they have to console the parents that this drug is, the vaccine although has been given by IM, it's a wrong process but it's not going to cause any harm. So we have to be very precise while dealing with pediatric patients. Most often what happens, the formulation, especially the anti-tubercular drugs, these are not available as syrup, so readily available. Most often they come in tablets. And again, you calculate the anti-tubercular drugs based on weight. So if you don't get the correct weight, you have to calculate the dose. If you say half tablet, it's very difficult for the parents to know what is half tablet basically. If you 1/4 tablet, it's very difficult to bring 1/4 tablet. Similarly, when preparing the oral suspensions, we see even many a times, if you suppose you write an amoxicillin chlorinic solution to the parents, it comes in dry suspension, you have to prepare in liquid. And there's a particular liquid solution which is offered in the package itself. So when the parents pour the liquid solution, usually it settles down, it comes down below the line. So what happens, the parents will actually pour some extra water into it to make the solution better. But that way again, what will be happening is you are over diluting the solution and the drug will not work. Many times what happens, once you prepare the solution, they will buy only one package. It will last for 3 days, but the doctor is prescribing for 5 days. So once the solution comes down, they will put some extra water. And again, it will make a solution and they will use it. So this is how the errors occurs. So whenever you are writing a prescription or giving a drug to the parents, you have to, because the child will not understand, you have to specially, elaborately tell the parent that this is how you prepare the solution. You have to keep it in a room temperature, keep it away from the child, and don't remix the solution again. You have to completely use it and then you have to buy a new one. So 5 common causes of medication errors include the incorrect diagnosis. We talked about prescribing errors. Dose miscalculation is again very important because many a times in children you have to be based on weight and age. Poor drug distribution practices, drug and drug device related problems. Many a times when you are using it in indoor patients, sometimes you use the syringe pumps and the volume pumps. If you don't know how to set the syringe pumps or the volume pumps, it comes with decimals, and if you do not put the correct decimals, the child, most of the time we see that the child gets overloaded with fluid. This fluid overload, the child will go into CCF. Many times you have seen this because if you don't put the decimals, suppose it is 10.1 ml per hour, the sister will put 101.1 ml. So that it may cause catastrophic. There could be incorrect drug administrations, and most important, failed communication and lack of patient education. So the most common prescription drug errors like lack of awareness of expiration dates. Although expiration dates are printed, but many patients do not pay attention to the date, taking the incorrect dose, rate of uses, and most important, as we will elaborate, at what time of the day the drug should be taken. And most often, many of the drugs are combined together, which can have some catastrophic effects. So in the morning only we talked about all this, and most of you are from nursing stuff, so you all know about these 10 points. The right patient, right medication, the right dose, right route, the right time, the right patient education. The most important thing is right documentation and the right to refuse. If you not understand what has been written, even if you feel that the drug is not to be given, you also have the right to refuse it, and the right assessment and right evaluation. So what are the causes of medication error? Most commonly we see medication error in our intensive care units, and mostly it's because of workload and fatigue. Because since we have a big ICU, there will be around 5-6 sisters looking after around 15-20 babies, and most of the time, by the time we have timings for drugs, you are fatigued. You will ask somebody else to prepare the drug. If the drugs are not prepared properly, there is always a chance of human errors. The inexperience is the most important thing. Lack of training, poor handwriting, and oral orders. Here I'd like to focus one thing: inexperience. There's one during my first few days of practice after passing out my MBBS exam. I was working as a resident doctor in one of the hospital. So the doctor, there was surgery placed, and the doctor came in and advised kneel orally from 8 a.m. So sister was inexperienced with a new sister. She thought it's a drug. So the sister wrote it down in the prescription, go and bring NIL, NIL. So the whole patient was moving all around the city, and by evening the parent came back. The father came with they were all annoyed, they were angry that this drug that the doctor has given, we couldn't find out in any of the market. But it was actually NIL oral. So while prescribing drugs also you should be very, you should look into what the doctor has written. Similar thing as also I've seen many times doctor writes CST after giving rounds. So one day the nursing superintendent came and said, see, the doctor has already given a direction, and every day is giving a direction that CST, but I have not seen this CST in your what do you call it, in the nursing paper. Where is this drug? Where is this new drug? So these things can happen. So these are lack of inexperience, using abbreviations, but these are true stories, I would say. So pharmaceutical factors like excessive prescribing, like confusing medication nomenclatures, packaging or labeling, lack of effective policies and procedures, and workplace factors like excessive workload, noise, interruptions by the sometimes by the attendant itself. Especially in pediatric patients, whenever you are preparing a drug, the father and mother will come to you and say, are you putting the right medicine? Are you preparing it correctly? So they'll be on top of your head. So there's a, if you're not confident enough, you'll dare to make a mistake. So factors need to be considered in pediatric patients before administering any medication, whether a drug is safe and approved for use in children, what is the appropriate dose for child age and weight, and what key information about adverse reactions need to be communicated to the parent or the caregiver. So how can you ensure safe medication administration for pediatric patients? We always employ weight-based dosing, which is ordered in milligrams, especially when you are preparing the inotropes. So we always say in microgram, milligram per kg per minute. So it has to be correctly written, the formulation has to be correct, then only you are going to make it a correct formulation. Use a recipe for compounding, choose the appropriate dose. So the most important thing is that always better to use the oral disposable tablets compared to the suspensions. If the drug can be given IV, it is always better rather than giving IM. And choose the best delivery method. There are 3 checks. We look at the frequency, how often the medication must be given. We look at the route, how a medication is given, and time, that the medication is scheduled on the as per the medication administration record. For pediatric patients, the best is always the oral delivery route because it is always non-invasive, it carries a low risk of pain, and parents also generally feels comfortable whenever you give a oral route. But if you give a IM or IV route, putting a cannula itself is sometimes very difficult, and children also doesn't want to keep the cannula for a long time. So to avoid medication errors, we need to minimize clutter, we verify the orders, use barcodes, be aware of look-alike and sound-alike drugs. Here I'll just again give you a real-life example. One child was operated in another hospital for an ENT surgery. The child undergoes surgery. The child was crying in the ward. So the sister called the doctor that after post-operative the child is crying a lot. So the anesthetist asked the sister to give midazolam that the child sleep. So after the injection, suddenly the child had a respiratory arrest. The child went into a cardiac arrest and the child succumbed. And then they did a resuscitation and was shifted to our hospital. So when we took a history, what happened actually was that these are, if you look at the vials of midazolam and succinylcholine, they are almost same orange color, same size and same shape. The sister mistakenly took up succinylcholine and injected succinylcholine into the child, and child succumbed on the bed on the mother's lap itself. So these things can happen. So whenever you pick up a drug, and in our NICU, what we do most of the time, we keep a magnifying glass also. Sometimes the words are written so small that you will not be able to see also. So you better use a magnifying glass to be 100% sure that you are giving the right drug and in the right formulation. You should always involve the patient, the patient, the parents. Trust your gut, most important thing. And if you want to minimize the medication errors, the only 2 things that I feel is the most important thing is that you have to believe in yourself, and you have to keep training yourself and always be do your work seriously so that you don't commit mistake and don't blame others for your mistakes. Be proactive and track the medication errors. There is one more thing that we most commonly see in medication safety at homes. Most of the parents who are taking hypothyroid thyroid norms, parents taking anti-hypertensive tablets. So the parents always take up the pill, they'll just pop it. The child thinks the mother is taking some chocolates or gummy bears. So he's always inclined to take that medicine. So these medications are easily available. This is one emergency that we commonly encounter. The child has taken 10 tablets of Tylenol. Child will take 2 tablets of anti-hypertensive medicines. So we have to keep a track. All this medication has to be kept safely at home so that it is not easily accessible for the child. Especially you have to lock the tablets properly. You have to keep them in proper place. Prescription medicine, over-the-counter medicine and vitamin supplements has to be kept separately. One thing that we commonly see, of course not a medication, but kerosene poisoning. Most of the time the child takes up kerosene poisoning. How? Because these kerosene are kept in Pepsi bottles or in Sprite bottles. So when it's kept, and the kerosene always has a very good smell. So he sees the Pepsi bottle or the Sprite bottle. The child is, he's called upon by the kerosene can. Please come and take me. The child will he'll think this is Pepsi or it's Sprite, and the child takes it. So it's very important that you keep the medications or the things which are harmful to the child in a proper place and then in the proper jar or a copper bottle, so that the child is not inclined to these medications. So what is the most common type of medication error that we see is mostly wrong doses and infusion rates. And the most common cause where we are using abbreviation is the full names of drugs and similar name for drugs. So for a priority for a nurse with a medication error is, so whether or not the patient was harmed as an adverse reaction as a result of the error, all medication error must be reported, not only for patient safety, but for quality improvement purposes. And when your colleague makes a medication error, the patient safety and well-being are your first priority. So consequences could be medico-legal, can be loss of patient trust, civil actions, criminal charges, and medical board discipline. So this is one study which has shown that medication errors in the emergency department, mostly because of communication errors, 45% orders are not verbally repeated back. Converting doses, there is around 40.2% incorrectly converted. Selecting medication, there is 7.3% wrong, and measuring doses 32.7% wrong. So preventing medication error, establish consensus group of physicians, nurses and pharmacists to select the best practices. Introduce a punishment-free system to collect and record information about medication-related errors, and promote legible handwriting and complete spelling of medicine name. We should always discuss about the route of administration of in all orders. Write out directions completely, not once daily as spoken in the morning. Limit use of telephone and oral orders. Again, in pediatric OPD practices, we receive a lot of telephone calls from the parents that my child is having fever. The paracetamol comes in different formulations. We have paracetamol drops, paracetamol 120 mg in 5 ml, and we've got paracetamol 250 mg in 5 ml. If you say give paracetamol 5 ml, you don't know what paracetamol the parents have taken. So you have to be very clear whenever which paracetamol you have. Do you have the drop? Do you have the 120 mg or the 250 mg? This is a very common mistake that we most commonly encounter in our pediatric OPD practices. And secondly, for every parent, the child is a baby. So whenever the mother calls, the mother will say, my baby is having fever. So when you receive a call and the mother says, my baby is having fever, you think that it might be a small baby, an infant. But when you ask, what is the age of your baby? The mother will say, he's 16 years old. So for a mother, he's 16 years old, so he's a baby. So it is very important that you always ask the weight and the age of the child whenever you receive a phone call. Okay? Because otherwise you'll always misinterpret baby and an adolescent. So confirm identity of the patient before administering medications, and use standard administration time for hospitalized patients. So be aware, mistakes can happen at any stage, and everybody in the healthcare team can make a mistake, including us. Thank you.
Thank you, Dr. Bora, for sharing your expertise and also sharing your interesting experiences. Before we move on to our lunch break, would like to share a few information that Integra Ventures is starting a certified healthcare executive program in collaboration with Pratiksha Hospital, and we are starting this program from 17th October. The last date of registration is 14th October. The brochure is there in your registration kit. It's a 3 months program in both online and offline mode. There will be 10 modules of 30 credits, and there will be also a guided project, and the fee of the program is rupees 11,999. We are also providing 10% discount, and installment facilities are also available. The interested person may contact the numbers given in the brochure, or they may contact any Integra Ventures representative in the registration counter. There is also a feedback form provided to you all in the registration kit. Kindly fill it up and provide to us during the closing session, or our representatives will come to collect from you. Now we'll take a break for lunch, and the next session will start from 2:15. So we have around 1 hour 15 minutes for lunch. So I request around 125 participants to first go for lunch so that there is no rush. And that then they can come back, and then the next people can proceed for lunch. Thank you. See you at exactly 2:15 p.m. Thank you. Welcome back. Now we will move on to our next session, the fourth session of today's program on the topic Medication Safety in Oncology by Dr. Bhabesh Kumar Das, Professor and HOD Department of Surgical Oncology, State Cancer Institute, GMC. Dr. Das is trained in oncology from Tata Memorial Hospital, Mumbai, and joined Dr. B. Bora Cancer Institute, where he continuously worked for 28 years and retired from there as a professor in HOD Surgical Oncology. Thereafter, Dr. Das has joined State Cancer Institute and presently working as a professor and head in the Department of Surgical Oncology. Dr. Das is passionately involved with Ramakrishna Mission Ashram, Guwahati, and its humanitarian service. We would like to invite Dr. Das onto the stage. I would request Ms. Sangeeta Vaishya to felicitate Dr. Das.
So, good afternoon, each and everyone. Before I forget, let me thank Deepika for giving me a chance to be here this afternoon. So, dear all, especially Dr. Urmi, Sashiba. Urmi is actually my daughter-in-law. If I speak this way that way, she will tell my brother. And so let me also bring to you all greetings of Vishwakarma Puja Day. And incidentally, the Vishwakarma and Safety Day, today is actually the World Patient Day. And the Medication Safety Day is the slogan for this year. So with this, I'll start my the presentation. I don't know how much good in the subject. Anyway, so medication safety in oncology. I am never tired of telling this. Just to live among so many calamities, hostilities, ill feeling, disaster, diseases is just a miracle, as great as to have been born. So just in living is a miracle, like our birth. So in our life, every day there are some dangers, some issues like this, and cancer is one of the miracles, especially the cancer and its treatment. It has got a lot of harms which can be associated with miracle. We will go into discuss. So just to introduce this subject, see, the WHO estimates that 1 in 10 patients suffer preventable harm even in a very advanced hospital setting. So 1 in 10 is a very big number. So medication safety has become a challenge today, and this is really a priority concern in all of the health institutions, hospitals and all. Hazards and unsafe practices still persist in spite of having the improvement in the treatment, evidence-based management. Today you cannot say like the opinion. No? Yesteryear's treatment was an opinion-based. You maybe mostly, I believe mostly from the nursing career, no? Okay. So let me be really basic. See, evidence-based management, earlier we used to operate or do treatment. My professor used to tell me, that's why we are doing. But now everything is evidence-based. So this has been experimentally proved, and this has been gone through a very rigorous process, and ultimately you get a treatment policies. So there are a lot of guidelines you can find how to treat a patient. So in spite of having all the improvement in the treatment, in spite of having the technological advancement, Today you don't have to stitch by hand. You have all the paraphernalia, like you have the staplers and all. No? So these are the little bit advancements in technology. So again, lot of money has been invested in your technology. Then a lot of research, seminars, workshop, skill development, training. In spite of having all this, still we are having this errors in treatment. And though we have the dictum is what? Primum non necessary, means first let us have the philosophy, let us do no harm. If you can't do any good, at least you should not harm a patient. So that is our dictum. So in spite of having all this or saying this, still we have some the dangers and the misfortunes or some mishaps like this, or errors in judgment, errors in diagnosis and all. So just to say what is safety. Safety by definition is prevention and control of injuries or other consequences or harm caused by the accident, right? So in a hospital setup, okay, especially this safety is concerned in everywhere. Even in day-to-day life, as I say, just to live is a great miracle. So anything can happen to anyone in any time. That today, this afternoon also you can have a very big jolt or you can have an earthquake. So the important thing is this: you should be ready to face any eventualities and get out of it. Okay. So to err is human, but this error can occur in any setup. So these errors are basically the human error or system error. Okay. See, human error, just to simplify and just to give an example, error, the human error may be the act of or error of commission. Understand? Or it may be omission, act of omission, or it may be act of execution. Just to explain in a very short way, act of commission means suppose you are doing a laparoscopic surgery, you committed mistake, okay? You just injured a bile duct. So this is the act of omission, okay? So commission is this, omission, this is a commission, you have committed a mistake, right? Omission is suppose you had cut a bile duct or injured a bile duct, you did not stitch it. So you had omitted what was actually had to be done. Okay? These are the errors. These are the things. Okay? And error of execution. Error of execution means basically doing the right thing not in a proper way. Okay? So if people are asked to put a Foley's catheter in a male patient, and you put a catheter halfway in the urethra and inflate the balloon. You know you have to put a catheter because the patient is not passing urine, but you are doing or executing very erroneously, right? So these are the things we should be very, very careful. And system error, see, it is a hospital or health setup is known by its system. So also in everywhere, whether it is a service station, motor car service station, or an institution or a school, there should be some system. So when error occurs, it is not definitely the one cause that leads to an error. Okay? So mostly this is this failure in the system. So if you have a good system, then you cannot have an error or you can have the less error. Okay? So that's why I have written here, it's better to address why the system failed than to who did the mistake. This is the wrong thing. Tumhar karne it hoigal, tumhar karne patient died, or tumhar karne this. No, it is the system. See, system, I am very fond of telling this, the system is, one fellow he went to America, he said that, okay, you American people always produce the Nobel laureate and all, but in India, in spite of having so many brainy people, so much of brain, India is not producing a Nobel laureate. Why? Then the American professor said, no, don't say America has ever produced a Nobel laureate. America, but it is the American system that can produce. Because if you go into that system, no, you cannot get out of it. You have to read, you have to excel in that subject, you are very interested in physics, they will make you read physics, they will make you practice this, and ultimately you have to get the Nobel Prize. Because this system, so the system is very important. When you be attached to a hospital, you will be able to appreciate. Now, safety in oncology is as important as any other specialties in medicine. So when we talk of safety, or when there can be a harm, so harm can be to the patient, okay? We can have some dangers or something harm or errors of diagnosis, you can harm the patient. The harm can also occur to the caregiver, like doctors, the healthcare delivery people like sisters, nurses, and the harm can also occur. And it can occur also to the public at large, okay? So everybody should be cautious about it. And you know the patient to gom palai, caregiver, suppose a patient which has been taken up for, say, without doing a HIV test or hepatitis V, and you happen to be infected with the blood, so sister will get it, okay? And if the public at large can sometimes, have you heard about the typhoid Mary?
Yes.
Huh? So what is typhoid Mary? Those who do not know, the gallbladder stone that was taken by the patient, he crushed that, and whole of the public got infected with typhoid. So there are situations where public can also be affected or involved. Okay. Now just to introduce oncology, I have been saying that you have to say about the medication safety is only. I am not talking about only medicine, but medication safety is today's slogan. Actually, the patient safety. Okay. Now, just see, when you say oncology, basically there are three important areas like surgical oncology, medical oncology, and radiation oncology. But there are also the allied subspecialties. Dr. Urmi is going to tell the other specialties. Sashiba is there. So anesthesiology, then pediatric surgery, or whatnot, the transfusion medicine. So all are allied. So everything is included in oncology, right? But basically there are three important: surgical, medical, and radiation oncology. Just to say a few things about the surgical oncology, as you know, surgery is the most complex health intervention, and operation is the most important thing, no? Most of the people say operation, but I don't like this operation. Operation may be anything, especially you should refer to a surgery. Apnar operation hoy gol nahi? Are what operation? Soumar alpha has from Bhutan, the alpha has been divided. That is also operation. Okay, we are concerned about this surgery. So surgical area or surgery is a very complex health intervention that can happen to a patient, especially in cancer. Now, the oncologic surgical procedures, they carry an increased or heightened risk because of the nature of the disease itself. Okay, you know in time that the cancer surgery or cancer, the typhoid, or if it's malaria, it is malaria, it occurs in malaria, it happens to, it is similar to in each and every patient. But in cancer, the same breast cancer may be different in different patients, no? Because the breast cancer, one is having the age is different, one is menstruating, one is not. So cancer, you cannot say this is the one thing. So due to increased risk or nature of the disease, each patient presents with a different stage, okay? You may be knowing the stage. And there will be the patient factor. What did I say? The procedure itself and the patient, okay? Now, as I said earlier also, the more than one cause theory of accident can be aptly applied to many surgical patients during the perioperative period. So there is not a single cause that can be attributed to a harm which happens to a patient. Now the well-recognized errors is what? The wrong patient in the wrong operation room. Have you heard or have you read in a newspaper recently, I think, sorry to say, in Karimganj or somewhere, you know, a lady was taken up to the theatre. She was, laparotomy was done and said, no, she is not ready for the birth. Full-time baby is not there, so they close it. Have you heard?
Yes.
Huh? So that is possibly a wrong patient in the operating room. Okay? So I'll tell you, we have to have some precautions, a checklist for this. or surgery on the wrong side. Yeah? Many people say, I don't know, I have not heard. Sridevi's mother was opened in the wrong side of the brain for brain tumors. I don't know how far it is correct. But this can happen. Okay? Wrong side of the skull can be open if we are not very careful about this. Okay? Or wrong procedures. Okay? What actually needed has not been done. Even there are instances, instead of gastrojejunostomy, people have also done gastrocolostomy also. Just imagine what can happen. Okay? In the right side there will be stool only, not the stomach content. So things can happen. Okay? Failure can be there, or as I said, to err is human. So this can happen. Or failure to communicate changes in the patient condition. See, many of the time our patient had a chest X-ray or had a CT scan done quite few months ahead, and then they come. When you operate, so the condition is quite different. Or the day of operation, or the change. So if we fail to communicate, that is also an error. Okay? The disagreement about the procedure. So because of this, actually, many of the hospitals, especially our institute, the Cancer Hospital, Bora, we have a joint tumor board or multidisciplinary tumor board. So where we pick up every patient, and every day the meeting is there where we discuss what is the best treatment for that particular patient. So this is also a very important step in preventing error. Okay? Then disagreement about the procedures, because you know, if you have seen the operation data, this is almost like a battleground. All the chiefs, the battle starts in the brain of the general, no? So all the generals will start fighting. There are anesthetist people and everything. And there are some occasions where you have heard about the written instrument and so on. So all these things can happen. Okay? So one should be particularly very cautious, or one should be so safety measures. So this starts once the patient is admitted or just before the surgical procedure, pre-operative. It can occur in the diagnosis. You may have a wrong diagnosis. Okay, the patient selection should be good. So many times we don't. The patient comes with a blood investigation, but we are not interpreting the blood reports well. That is also one of the errors. Okay, instrument report, but there also we miss sometimes. So correct blood parameters should be there. Type of the surgery should be performed. It should be very. And pre-anesthetic checkup is very important. I'll go to the checklist. Okay, so every patient has to have PAC or pre-anesthetic checkup before he is subjected to surgery. Then intraoperatively, the confirmation of the patient, the disease site, the procedure, the anticipated blood loss, maintaining sterile intervention, that is during the intraoperative period. Okay. Now see, the WHO, even this day is a strategy formed by the WHO, if I am not mistaken. Then WHO has come up with a lot of strategies. Okay, they have even come up with some of the slogans like safe surgery, what was that? Clean care is a safer care, safe surgery saves life. Okay, surgery should be safe. So WHO talks about the surgical safety checklist, okay, where they have given a special guideline what you have to follow. So if you have guidelines, then the chances of falling into trap or chances of making error is less. Okay, checklist means you have a list. Suppose tomorrow what will you do? If you can make a check, okay, morning I'll get up this, we'll have breakfast, then wash clothes, doing this, we have to clean the fridge and all. So if you have a checklist, next day you'll be happy to see, okay, what I thought, everything has been done very well. Okay? So WHO has given a different checklist. You can see this in the net also. So if I can read it, so just sign in just before the patient. I don't think if you can read from there, it's okay. Patient should be confirmed, the identity of the patient, the site, the procedure, the consent, so everything has been there. Okay, consent is also a very important thing, because today the days of litigation, the consent is very important thing. Understand? And consent should be very willful, or consent should be in a very concise mind where he is awake and all, and especially there should be some witness also. Consent, you understand, no? Consent in will is different. Understand? Suppose you are telling, no, we will not go to Sankaradeva Nethralaya, any of you, we will go to movie today. No, we have some meeting there, I have to go. Then your friend says, no, let us go now, we will not go to, nobody will come to know. Ultimately, if you give consent, but against your will. Understand? You didn't have any will, but ultimately you are forced to give a consent. So consent is very important, because in litigation these things comes into it. Now the site is marked, okay? Many a times right breast, left breast, because everywhere, you don't think the breast is the bigger thing, so you don't have to mark, nothing like that. The sisters or those who are in the pre-operative room, they should mark the site, okay? Now, then pulse oximeter or patient functioning, then does the patient have a known allergies and all? So these things are taken, a thorough history is taken by the anesthesiologist and all. And to be very frank, each and every hospital has its own checklist or own performa which need to be filled up before the patient is taken into theatre. Then timeout, confirmed that all the team members are there, and one should be sure who is operating, who is assisting and all. The surgeon, anesthesia professional, nurses, so they should verbally comment that yes, this is the patient, this is going to be done here, okay? So the errors are minimal. The anticipated critical event. So I'll not go into it. So this has to be done. And in sign-out, you see, nurses verbally confront the team. So this is a common practice, no? Suppose you open up the abdomen, so nurses are asked, or surgeons are, is the count is ready and all. You have seen in the operation theatre, there is a board, no? What is the procedure like, who is going to do, what time you will started it, how many swabs, how many pads, what are the instruments we have in our state cancer institute. So these are the actually the guidelines, or these are the guidelines given by WHO, which will prevent or minimize the errors in diagnosis, and this will increase ultimately the patient safety. Now, few lines about the medical oncology. The question was the safe medicine or the, see, chemotherapy drugs have the inherent risk. Chemotherapy drugs are not like a drug used as an antibiotic or the antipyretic or something like that. You know, the chemotherapeutic drugs mean the cytotoxic drug. These drugs will kill the cells. And if you allow me to be too basic, because if the 10 cancer cells die, 10 normal cells also will die. Okay? Suppose in a room there are 10 militants, we don't know who is the militant, who is sitting there. You go on firing from that side, the 10 militants will be killed, or not 10, 3 will be killed, another 3 or 4 normal people will be killed. Similar thing happens in the chemotherapeutic drugs is used. Okay? Normal cells are also killed. So you give a rest for a month or 3 weeks, then normal cells again regain or regenerate, again it gives a chemotherapeutic shots. Okay? So that's how the chemotherapy is multi-cycle. It is not a single cycle that the chemotherapy is given. And it is also a multi-drug, that's why what you call multiple drug chemotherapy. You know why multiple drug? Because every cell goes through a different cycles of the cell divisions. Okay? So you have to choose different drugs which will act on the different cells. Okay? Understand? Suppose inside the room there are a lot of people. There are some toddlers, there are some the young child, there are adult, there are older. For everyone the food is different or killing thing is different, no? So you have to choose chemotherapy agent from different groups acting on different cell cycles. So ultimately the chemotherapeutic drugs are very toxic, okay? And they mostly harm, so second line, mostly harm the rapidly dividing cell. You must have heard or must have seen or felt, like when chemotherapy drugs are given, the usual thing, the hair fall is there, okay? Or you have a great the pharyngitis or the nausea, vomiting, okay? So this is because those cells which are mostly dividing, so active. Hair follicle is active, and these cells are very rapidly growing, or the hair follicle. So if you give chemotherapy, these are actually mostly the chemotherapy that acts in a dividing cell. That's what I am trying to impress on you. And now certain drugs are very specific toxicity, like they can be very cardiotoxic, like doxorubicin, you've heard the name, at least you heard the name. So I am a surgical oncologist, I don't know much, but these are the basics I am talking about, okay? So this patient has to have a thorough cardiac checkup before the patient is taken up for the chemotherapy. Many of the patient has to have the echocardiography or their status of the heart quite nicely assessed before starting a chemotherapeutic drugs. Like neurotoxic or platinum based drug. Platinum is a very toxic also. So they usually cause the neurotoxicity like cisplatin if you heard, or they are nephrotoxic, cisplatin or ifosfamide. These are the names of the drugs which are very toxic to the kidneys. Okay? And myelosuppression. Myelosuppression means the bone in the where there are the blood solid components are born, no, means generated or developed. So there will be the myelosuppression in there. There will be WHO count will go down, platelet count will go down. There will be anemia. So these are the inherent risk of the chemotherapeutic drug. But that does not mean that we will not use. We should be very, very careful while using this chemotherapeutic drug. So, and the selection of the patient is very important. Who is going to chemotherapy, that is also good. And another thing I just wanted to impress on you, I can understand most of the people are here, the nursing staff, and you may be required to execute these chemotherapeutic drugs. So if the drugs can come out of the vein, extravasation, understand? So that is a very bad toxicity that can occur, because some drugs are very irritant or vesicant. They'll be all bully or everything, whole the forearm or where they are giving this chemotherapy drug, the whole skin will slough off. There will be a very bad wound and all. Okay, so one should be very particular. Have you heard of the chemo port? Heard chemo port? Nobody. So just to avoid this thing, extravasation or irritant possibilities of a chemotherapy, there is a port, a small, what do you call, means a small gadget, okay? So where you can inject the chemotherapy drug. So what we do, we put it in the vein, okay? The port, I didn't get the, so port is just put underneath the skin. So next time when the patient comes from the chemotherapy, we don't have to have the veins or venesection or the cannula or the cannulation of the vein to give the chemotherapy. It directly can puncture this chemotherapy port and you can give medicine. There are certain things you can give 1,000 or 2,000 punctures you can make on that membrane without causing any damage to the port. Understand? Port মানে একফালে আনিবা টেমান নিচিনা এটা থাকিব একফালে তোমাৰ IV নেগুডাল যাব that will go into the central vein, okay, and that the gadget will be just below the skin. So these things can obviate the bad effects of chemotherapy. Now, or safety measures of patient selection very important. You cannot give chemotherapy to each and everyone, the old age, the poor general condition. Blood chemistry should be good. One should not have anemia. The renal function, the liver function, everything should be okay. And 2D echocardiogram, as I told just now. And in chemo, and post-operative or post-chemotherapy measures also should be good, like regular checkup. Because if you give a chemotherapy, send the patient home and don't check for the blood test and all, the particular patient may have the gross anemia or pancytopenia, means thrombocytes will be low, WBC count may be low. So you have to be very careful or be very vigilant while after giving the chemotherapies. Okay, and patient can have a very febrile conditions, diarrhea. Okay, so for this there are certain medicines also which we call the antidotes for this the chemotherapy agent. Like Mesna is one for cystitis, because sometimes there is a hemorrhagic cystitis, so you have to give the Mesna then. And many times foods are to be avoided in the post-chemotherapy patient, because foods are not very hygienic sometimes. Okay, these are uncooked things, so you are not given, because after giving chemotherapy, the patients already have a very immunocompromised state. Okay, এনেকুৱা কৈছে মানে পেশেন্ট ভালে হৈ যাইছিলে, ভালে হৈছে একদম তোমাৰ কিবা ভগৱানৰ একদম ভৰি ধোৱা পানী খুৱাই দিলে, খুৱাই দিয়ে একদম পুৰা গাত ইনফেকশ্যন হৈ পেশেন্ট যাওঁ অৱস্থা। চ' ভগৱানৰ পানী একদম মূৰত অকণমান কিবা আৰু সেইটো খোৱা লোৱা নাই আৰু। চ' ওৱান শুড বি ভেৰি ভেৰি vigilant about this in the post-chemotherapeutic period, and they should avoid very crowded places also. আজিয়ে তোমালোকে মাস্ক পিন্ধা আৰম্ভ কৰিছা, but you must have seen those take chemotherapy, they always wear masks just to prevent the cross infections. Okay. Now, a few things about the, I'll be closing, radiation oncology. Okay. Radiation oncology means where you have to treat. This is also a local form of treating cancer, so I'll give you radiation. Okay. So hazards of radiation is well known, no? You must have heard about that Nagasaki Hiroshima bombardment or the Chernobyl nuclear power in Russia. Okay. So you know, following that radiation leak, okay, how many people died prematurely? Okay. How many children were born with disabilities? Okay, and how many people become sterile or disease, or there appeared cancer. So there is a gross side effects of the radiation. Similarly, while radiating a patient, especially in the cancer hospitals and all, and also in the diagnostic setup, where X-rays are involved, there is always a chance of radiation hazard. So you may have seen most of the people who work in the laboratory or in radiation, they wear a badge, especially wear a badge. Have you seen? This is called the dosimeter to check the LTD badges. Okay, I don't know. Or before that, let me see, the effect of radiation may be acute, subacute or chronic. Acute, there may be mucositis, okay, or there may be diarrhea, or there may be a sickness also acutely. Radiation sickness as we call. Sickness, you understand? Sickness and illness, there are two different things, okay. Kumar will say, oh, she has not come to, she is ill. Ill man are serious. A sick man is bad like say, there are motion sickness. Motion sickness is hospital bharti na hola hobo. So sickness. So there is always a radiation sickness. After radiation, people don't get well and all, and this passes off with this. Okay? Then subacute. This is a special type of, you may remember, Lehermit syndrome, where electric shock-like sensation down the periphery upon the sudden flexion of the neck. Irritation or pins and needle sensation. This is mostly because of demyelination. Myelin number, nerve upon the sheet, the myelin sheet. Because of the radiation, the myelin sheet is destroyed. And when naked, electric wire, the insulator, black kulida, jota shock like electric wire. It's almost like that. You give a radiation, there is demyelination, and you have all the pins and needle sensation. And chronic, there will be skin pigmentation. There may be sterility of male patients or females also. Then second primary, because you had a radiation for any other reason, a patient in the younger age had Hodgkin's disease and she or he had the radiation in the neck or some area, and subsequently the patient may have a thyroid cancer or breast cancer. So these are the radiation effect. And just to counter effect or counter this bad things or hazard, you can adopt some safety measures like precision-oriented radiation therapy. At one point of time, we gave radiation like cobalt-60 and all it was something like non-conformable. Non-conformable visa, এনেকা মাৰিলে একদম সব ফালে ৰেডিয়েশ্যন হৈ গ'ল। ইয়াতে ৰেডিয়েশ্যন গোটেইখিনি ৰেডিয়েশ্যন হৈ গ'ল, বুজিছা? But nowadays the days of conformal radiotherapy. That means image anatomical structure. যিখিনি তোমাক ৰেডিয়েশ্যন থাকে like the surgeon's knife. Okay, you can give a radiotherapy. There are very high-tech machines are now available there. So, like intensity modulated radiotherapy. Now we can just calculate the dose that this particular areas of the brain or particular area. So suppose there's the prostate is there, this area needs a intensified dose. So you can really allow the photon beam intensity to be modulated in order to deliver specific dose to a particular target. So in the physics, there are the radiation physicists are there. They calculate it, they make out a chart. Okay, so according to that, you can be very, very precise in delivering the radiation dose. And nowadays they are called the fractionization of the dose. Fraction means ki bhanga. Okay, if you have a particular dose, a 50 centigrade radiation is there needed, so you can give more radiation per day. Okay, and overall duration is less. Edinot, I do 5 days a week. Okay, 5 days a week. Shonibar, Deori, Nidu just to recuperate the normal cell. But in the 5 days a week, you fractionize the dose so that the actual duration is less and you have the side effects is less. Okay. Then besides this, you must have seen radio protective seal. Haven't you seen? Extra korbe bola most khan Borma khan pindi loy nohoy pindi saisa. The heaviest metal is lead. You know? Huh? And what is lightest? Lightest I don't know. Anyway, so lead seals are very heavy, so you have to wear this lead seal because these are impervious to radiation. Okay, and many people before that, your patient selection is very important. The collagen vascular disease, inflammatory bowel disease, and the patient general condition is if not good, there you should not give the radiation. Okay, these are the actually the safety measures. Okay. And if you want to radiate the oral cavity or something in the cancers in the oral cavity, if the teeth are regular, because our patients, you can see the oral hygiene is so bad. Okay, if there is bad oral hygiene, bad teeth, the caries. So if you irradiate this, immediately there is some gingivitis or some very bad radionecrosis. The whole bones will necrose. Okay, so bhalat ke bhai So before radiating the mouth cancer or oral cavity, one should be very particular about the oral hygiene. And regarding the TLD base, this is thermoluminescent bag, thermoluminescent dosimeter bag. Okay, so many people use a badge here. Okay, the radiation which is scattered, কিবা তো অলপ চলপ তো ৰেডিয়েশ্যন ওলাবই না। তো বহুত চাৰ্জনে দেখিছোঁ দেখোন হেৰি কৰি থাকে দেখোন চি আৰ্মৰ কাম কৰি থাকে দেখোন বুজা চি আৰ্মৰ কাম ERCP ষ্টেণ্টিং কৰে বা ধৰা বোন ফিক্স কৰে বা এক্সৰে ল'ব লগা হয়। অ'কে, চ' সেইবিলাক ডক্টৰে হওক বা ষ্টাফে হওক দে ৱেৰ ইউজুৱেল বেজ। সেই বেজত কিমান ৰেডিয়েশ্যন তোমাৰ পালে those will be calculated. Okay, these are the those TLD badge, thermoluminescent dosimeter badge, and on the down below these are the jackets. Okay, lead jacket. So a badge bilakor tumar kiman permissible dose over they will calculate. This actually there is a small chip like thing. One chip like thing. You just take it out and send it to Bhava Atomic Research, I believe. Okay, they will calculate the dose. তাহাঁতক কওঁ যে তোমাৰ পাৰ্মিচিবল ড'জতকৈ তোমাৰ বেছি হৈ গৈছে, ইউ টেক 1 month ৰেষ্ট, কম্পালচৰি ভলাণ্টাৰী উইথ অল পে'মেণ্ট ফেচিলিটিজ এণ্ড অল, বুজিছা? আৰু মেনি অফ দ্য থিংছ ডক্টৰ্ছ গেট এ স্পেচিয়েল এলাউন্স কল হেজাৰ্ড এলাউন্স। অ'কে, ইফ ইউ ডোণ্ট ন' আই এম টেলিং ইউ। চ' দিজ আৰ দ্য প্ৰটেক্টিভ মেজাৰ। নাও few things about the nuclear medicine. Have you heard nuclear medicine? Huh? Nuclear medicine is another branch, especially here the radioactive pharmaceuticals or radioactive tracers in the form of radiopharmaceuticals drugs are used. So these are basically used for PET scan, positive emission tomography, PET scan, bone scan, so bone scan, PET scan, tomar 8 drug use hoy. Radiation pharmaceutical mane, these drugs can have the radiation. These are actually special isotopes, like technetium-99. Okay, these are used in bone scan or 18 fluorodextroglucose. I just forgot. So these are used for either diagnosis or treatment. So ebilak di jodi diagnosis and treatment use kora, you can have the again radiation pare. So the safety measure says radiation exposure is based on LRA principle. LRA principle, you can use this word. LRA means as low as reasonably achievable dose. Jiman para kom dose di pela to diagnosis koribo para therapy koribo, this is good. That is called LRA principle. Safety measures in workplaces, maximum 5,000 milliram per year is permissible. Is it best to follow? So this badge will give you the exact dose, how much dose you are exposed. So this is the permissible dose. Otherwise, you have to have a compulsory rest or compulsory leave. Okay. Then therapeutic radioisotope require hospitalization, radiation isolation ward. The radiation is that demand her. That tomar khorot gusi jabo noara. Because khorot to our family. Last line I wrote niki somewhere. Avoid close contact with the family members for minimum 5 days. Something like COVID period COVID nisnai hol radiation diar pisot amar je PET scanner dia bottle pani khaba loi ja bottle to ghor anibo nidiu karon bottle to radiation thaki jabo karon bahut long noy to ratipa gole abeli mane aibole because you know the radiation decay, you know decay mane ki radiation dose go to naikya hoy jabo even few of the centers amar eto kora nai jot to therapeutic radiotherapy hoy ধৰা total thyroidectomy কৰি পেলাই radiation দিলো বা prostate কত দিয়ে ধৰ radiation দিলো সেইবিলাকৰ যিবিলাক urine fishes এইবিলাক যে হ'ব excreta যাব those may also have the radiation বুঝা সিহঁতৰ কাৰণে special safety tank আছে আৰু সেই safety tank কুটো বেলেগ এটা segregated area লিখা যেন লাগে judicial disposal of the patient excreta okay to decay in a special area সেইবিলাক যেটা decay হ'ব তেতিয়াহে তোমাৰ safe হ'ব it will not cause any harm to the general public and you have a special dosimeter dosimeter means dose the suborder radiation and if anybody has given a radiation this thing the maintaining a distance of at least 2 meters while sleeping ekalego bona mokollo covid nistai boli now having said this the take home message is safety is everybody's business. It is not that the surgeon has to be taking precautions and all. The whole system and each and everyone, from cleaner to the chief surgeons and HOD or the management, everybody's business. And learning from mistakes is a great quality for positive attitude. We learn from mistakes. We learn from failure. Failure is the pillar of success, no? And if you can, if I am permitted to quote Swamiji, failures are the beauties of life. Swami Vivekananda says, what life is without the failure? Life is a failure is the cure life. So, but you have to learn. This is a learning curve. You have to, any bad situation to me, make it a challenge. There cannot be a bad environment for you. So these are all challenging platforms where you convert these bad things into challenges into your positive sides. Okay? So just to quote the James Reason, Professor of Psychology, University of Manchester, he said, we cannot change the human conditions, right? We cannot change the human condition, but we can change the condition under which the people work. Or you can change the whole system. এনেকুৱা চিষ্টেমত কৰি থবা যে তোমাৰ এইটো ভুল হোৱাৰ বা হেৰি চান্সটো কম so as to make error less provocative and all. And errors and mistakes and these things is very, very bad things in life. And just before I end, have you heard about the second victim? Being a surgeon, many a time we have lost patients, okay? Or not surgeons, or maybe as operating team as a whole, I am telling you. So you cannot imagine the chain of emotional breakdown, emotional changes, okay? And even to the extent of depression, sleeplessness, everything can happen to a surgeon. Because see, there is always a doctor-patient relationship or attachment, and in spite of having your best of the best intention, if you lose a patient, you can always fall prey to all this emotional breakdown. Where this surgeon or this is called a second victim. And the whole people, all the nursing and whole management should be very attentive or be aware of this situation also. Okay? So this finished. Thank you. So I don't know if there are questions or not. And if I have done the justice to what I have been given. Thank you. Who?
Thank you, Dr. Das, for the profound and effective highlights on the topic. It was a very interesting session, indeed with a touch of your humor incorporated in your medical experience. Next, we'll move on to our fifth session on the topic pharmacovigilance by Dr. Urmi Chowdhury, an eminent academician who is working as an associate professor in the Department of Pharmacology, GMC. Dr. Chowdhury is presently the coordinator of the Regional Center of ADR Monitoring Center for the Northeast states and has also published many of her research work in pharmacology in various national and international journals of repute. We'd like to invite Dr. Chowdhury onto the stage. I would request Ms. Sangeeta Vaishya to felicitate Dr. Chowdhury.
Good afternoon to one and all. Respected Bhabesh, my elder brother, and my dear student. I am very fortunate to share the dais with one of my favorite students, Sashiba, who is the head of emergency medicine in Name Care Group of Hospitals. So, being a pharmacologist, it's my fortune to be present here today, delivering talks on medication safety in coherence with Pharmacovigilance Week, which starts from 17th to 23rd of September. So, being the coordinator, so what are the things we need to learn? Rather, I would say, I will have to speak retrospectively. Why? Because medication error, medication safety in pediatrics, in ophthalmology, in oncology has already been discussed by our esteemed speakers. So retrospectively, I'll have to tell you what is about pharmacovigilance. So to undergo a treatment, you have to be very healthy, because apart from your sickness, you will have to withstand the medicines also. And as we all know, every medicine has got certain risk. So being healthy is the first and foremost duty of, to be healthy is the first and foremost duty of every citizen. There are benefits as well as risk of medications. We can't say medicines are safe totally. Why? No medicines in this world is safe without any risk. Okay. So coming to what do we understand by pharmacovigilance? Because without setting a pharmacovigilance unit, nowhere in this country will get a NMC norms or NMC note for establishment of a medical college, establishment of a pharmacology unit, establishment of a dental college. Everywhere you need to know about pharmacovigilance. And we are the people, right from the doctors, nursing students, nursing paramedical students, even the patient's relative and the patient, they are the person who will report to the pharmacovigilance center. So what is the meaning of pharmacovigilance? Pharmakon, it's a Greek word that means drug. And as you all know from your BSc background or from your MSc background, because there are esteemed faculties of the nursing fraternity also here, what is the meaning of a drug? Any substance or product which is used or intended to be used to benefit or modify the physiological or pathological state for the benefit of the recipient. So pharmacovigilance is the science and activities which will relate to the detection, assessment, understanding and prevention of adverse effect of any medicine or any related problem. We are all aware regarding the thalidomide tragedy, isn't it? I hope so. You have learned thalidomide, it was a hypnotic drug. This was a drug which was prescribed in the late 1950s and 60s for morning sickness, sedative hypnotic group of drug. But later on, the babies which were born to those mothers came out with seal limbs, which is known as phocomelia. For that reason, this drug was banned during the Second World War time, and nowadays again thalidomide has come to the market. Re-emergence of thalidomide as a immunostimulant drug, which is used as an immunomodulator. So thalidomide tragedy, this has led to birth defects, most of them with absent limbs. As I have already said, these are the photographs which depicts children or the child born during that era with absence of limbs and artificial limbs. So to study the adverse drug reaction, as I have said, no medicine is safe in this whole process. So adverse drug reaction monitoring is the key prospect or is the key subject in pharmacovigilance. So what do you understand by ADR or adverse drug reactions? This isn't any response to a drug which is noxious and unintended. Okay? That is given, the dose which is given in a pharmacological doses form, not in a toxic form or not in a lesser level. That is in therapeutic dose range. Whatever the side effects or whatever the toxicities we get, side effects we get, that is known as the adverse reactions. So this may be a single dose or this may be for prolonged administration of a drug. So this is something different from that of side effects, because every medicine, whatever we give, has got a side effect. Side effect can be, we can avoid. Like after taking atropine group of drug, you may develop less sweating, less urine formation, dryness of your mouth and all. This can be avoided. We can avoid, but adverse drug reaction you can't avoid. You need to report. But we will have to know what are the things or what are the centers where we need to report all this thing. So this has been again divided under A, B, C, D, E. A means augmented. The effect which may be normal in certain circumstances or to certain persons may be very augmented in a class of person, in a class or category of patient. B means bizarre. That means the effect of the drug which you will be getting after giving this drug, it's in a bizarre shape. Number 3, C, that means chronic. You have given the drug for a certain period of time, but the adverse effects, whatever we will be getting in a long duration, that is known as chronic effect. And delayed effect, as you all know, delayed hypersensitivity reactions. And E is ending of use, okay? So what do you mean by A? that is type A augmented pharmacological effect. That is again dose dependent and predictable. That means you can predict with the giving of this amount of drug, these are the signs and symptoms which can develop. B is bizarre effect. This is dose independent. These are certain differences. Chronic, as I have said, C. D means delayed, end of treatment, and F is failure of therapy. In spite of giving all the treatment, the patient has not responded. Why it is so? Because of failure of treatment. Because of development of resistance. By this time you all know what is the meaning of medical resistance, drug resistance and all. This may be again due to certain genetic causes also. So possible causes of adverse drug reaction. This may be intrinsic, idiosyncratic reaction, mutagenicity. As you all know, we don't give certain medicines or drugs during pregnancy. Why? During the period of organogenesis. Why? Because during that time, if you give those medicine, this may lead to so many circumstances or so many failures of development of the organ. Okay? Carcinogenicity, metronidazole and all, this has been proven to be carcinogenic in rats, albino rats and all. Then coming to the term serious and very severe adverse effect. This is also one of the terminology in adverse drug reaction monitoring in pharmacovigilance. That means where the patient's life is threatened, patient needs to be hospitalized. Okay? Require hospitalization or patient may have certain disability. He can sue the court. Why? Because there has been some impairment of its day-to-day activities, congenital abnormalities, then intervention to prevent the damage. So economic impact of adverse drug reaction, as you all know, it is one of the 4th leading cause of death. And out of this, as we all know, 30 to 60% of the adverse drug reaction can be prevented. How? By either de-challenge or re-challenge. So what is the meaning of de-challenge and re-challenge? I'll be coming in my next slides. As we all know, a drug takes pretty long time for development. It takes 11 to 20 years for a drug to come to the market. Before coming to the market, a drug has to undergo clinical trial. Phase 1, Phase 2, Phase 3, Phase 4. Phase 4, as we all know, this is the post-marketing surveillance. And from the post-marketing surveillance, we can assume what are the adverse effects the patient is having or the mankind is suffering from the taking of this drug. So post-marketing surveillance is a very important terminology for in real life. Because you know in Phase 1 and Phase 2 we take a handful of patients, like 20 to 100% patient in Phase 1, then Phase 2 efficacy. Whether the drug is efficacious, whether it is useful for the patient category, because we choose a selected group of patients for that category of disease only. Okay? And Phase 3 is to confirm the patient size is more than 1,000. Okay? Limitations of clinical trial, as we have said, narrow population, because we will select a specific age and specific sex. And we don't consider certain population while considering a clinical trial. Because pregnant lady, infants, then geriatric age group, they are not considered suitable for doing a clinical trial. Yes. Why is detection and assessment of ADR inadequate in clinical trial? Because this is frequency of occurrence and a very limited period of time. And as we all know, for getting a rare or rarest side effect or adverse reaction, we need to categorize those patient incidence 1 in 1 lakh. That is 1 in 1 lakh, we will get only one patient of incidence of adverse drug reaction to categorize it as a very rare adverse drug reaction. Few examples of drug, as we all know, like nowadays we don't take nimesulide, we don't take rofecoxib group of drug, you all know these are what? Selective COX-2 inhibitors. Why we don't take? Because this group of drug has been banned from the market. Why banned? Because after going through numerous case studies, it was found that they are having cardiotoxicity effect. They are having certain changes. For that reason, this drug is not suitable for the Indian population, and this has been banned by WHO in coherence with FDA. Okay, in coherence with CDSCO, Central Drug Control Organization and all. So these are the examples of certain drug. Alpidem, this is something like Zolpidem, non-benzodiazepine group of drug. So why there is a need of pharmacovigilance? Number one, humanitarian ground. First of all, we all are human beings. We need to cater, we need to respect one's life. That is why insufficient evidence of safety from clinical trial. This is why we need to know regarding pharmacovigilance. Then, limitations of clinical trial, as already I have said, it is restricted to a specific group of population in a very less population group and for a short duration of exposure. That is why this is not evident, or this is not the sure shot whether this drug should be approved in the market or not. Reason 2, as we all know, medicines are supposed to save the life of the dying person or suffering mankind. So dying from a disease is sometimes unavoidable. In spite of doing your best, you can't save the life of the patient, but dying from medicine is unacceptable. And in India, we follow, because as we live in India, we will have to follow the Indian pharmacopoeia, we will have to abide by the pharmacovigilance regulatory authority that has been set in Indian environment. But in US and UK, yellow card and all, these were the powerful tools to measure the pharmacovigilance status. ADRs is expensive. As you all know, whenever a person has got certain adverse reaction following the intake of the drug, to treat that measure, you need to spend lot of money. That is why cost of drug related morbidity and mortality, it exceeds more than billion in 2000. This is one of the statistics published in American Pharmacological Association. Reason 4, you all know, we being from the institute background, we promote rational use of drug. So what do you understand by rational use of medicine and adherence? Right drug, right person, right patient, in right doses form, isn't it? Because if we prescribe a very costly medicine, the patient by somehow he or she will manage to take 1 or 2 doses, but after that, as soon as the money is over, she won't be able to continue the medicine. That is why cost effectiveness also should be addressed. Ensuring public confidence, okay? Ethics to know something that is harmful to the mankind should not be applied to a greater population category. So because of difference, as we all know, the drug which is very rampant or which is very much used in this part of the world may not be very much used in Western countries. So we need to know our essential drug list, the drug list which is very much suitable for this part of the world, the disease condition, as we all know, malaria, typhoid, Japanese encephalitis, we don't get all this thing in Western countries. So drug production will also vary accordingly. Distribution and use, availability, genetics. You all know, if you give glucose 6-phosphate deficient patient, Primaquine group of drug, patient will have hemolytic anemia and patient will die. Then the dietary habits. We are in the habit of having rice and other food materials, but in the Western country that tradition is something different. And pharmaceutical quality and composition, which we know as biosimilars, because the medicine which has been developed by Cadillac may be different from that of other companies. This is known as biosimilars. This differs in the composition. So WHO program, as I am here to talk about pharmacovigilance, its headquarters is in Uppsala, Sweden. Okay, and this has got certain coordinating centers all over the world. But in India, in Indian scenario, we'll be talking. We are having our headquarters, Indian Pharmacopoeia Commission in Ghaziabad, And we are having, under its umbrella, we are having Eastern Zone, Western Zone, Southern Zone, okay? And we being in the Eastern Zone, Northeastern Zone, our center, Guwahati Medical College, Department of Pharmacology, is the regional training center for imparting pharmacovigilance knowledge or collecting data, okay? That data will be sent to various centers. First to IPC Ghaziabad, then through certain other measures, it will be sent to Uppsala Monitoring Center in the Sweden. So we have to identify the early warning signs, evaluate the hazard, how hazardous that drug is. As we all know, adverse effect following immunization. After COVID vaccination also, so many patients has developed so many side effects, like neurological side effect, like GIT side effects, isn't it? So undertake research into the mechanism of action in the aid of development and to develop more safer and effective medicines. So this is the workflow for pharmacovigilance activity. Anyone can report. You may ask me, who can report? Anyone. The nurses, the medical students, the doctors, the ward boys, even the patient's relatives can report. They have to report any untoward effect after taking the drug. Suppose you have given penicillin injection, after 1 to 2 doses, patient have developed rashes, that can be also reported. And the reporter's identity is kept secret, and I will show you the 1.4 version of the form which is available in our center, not only in our center, all over the country, where what should be written regarding the patient details, when the medicine was taken, when it is stopped, for what reasons it was stopped, can it be re-challenged again and again. So from there, from our center, this will be sent to the Pharmacovigilance Indian Pharmacopoeia Commission, then this will send to the Uppsala Monitoring Center, and from there, they will generate a signal whether the drug should be banned or should be kept, not by a single report of ours, mind it. So there are also certain emerging trends in pharmacovigilance. One is material vigilance. We are already using stents, medical stents for any coronary bypass or intraocular lenses and whatever. All these are under the heading of Material Vigilance Program of India. Okay, so to minimize the risk for safety promotion, this is also reported to CDSCO. And there are certain centers which recognizes all those adverse effects with the using of those dilutional stains and all. Like Sri Sankaradeva in South India. This is the center which records all this thing, and we have also regional center which I won't go into details, AIMS New Delhi, and also in Department of Biomedical Engineering, Kolkata. This is also a regional center for taking all those adverse effects. Then another program is there which is known as Hemovigilance Program of India. Hemovigilance, this is with the use of blood and blood product. Because we are using plasma, we are using serum, we are using so many blood cryoprecipitates and all. So what are the adverse reactions that can occur with those group of things? So this is reported under the banner of Hemovigilance Program of India. These are also under the umbrella of PVPI, Pharmacovigilance Program of India. So there are certain important terminologies in pharmacovigilance. One is side effect, which I have said, this can be avoided, isn't it? Adverse drug reaction is any noxious or adverse event which occurs in the normal pharmacological doses. This cannot be avoided. So there is also the term medication error. As already my esteemed speakers, previous speakers have already spoken regarding prescription error. Because we the doctors, we are notorious for having bad handwritings. So that prescription cannot be followed. Instead of another medicine, some other medicines have been given. So medication error, very common. Then polypharmacy is very common. We used to give 4 or 5 medicines together. We don't think whether this is efficacious or whether there may be any untoward reaction with the giving of 2 medicines concomitant. Okay? Then As I have said, medication error is also one entity under the heading of adverse drug reaction. Serious adverse drug reaction, as I have said, this may be life-threatening, this may lead to disabilities. Otherwise, adverse drug reaction is non-serious. So a valid report consists of identifiable. As I have said, patient's details should be given. Identifiable drug, the product name, the label name, when the license, when it is manufactured, what is the expiry date, everything should be clear-cut. Identifiable reaction. You may think, oh, this kind of itching has developed, should I report? No, any damn thing can be reported, I'm saying. Identifiable reporter. The reporter's identity is kept as a secret, but you will have to give the identity. So this is the 1.4 version of Adverse Drug Reaction Monitoring Center, how to report a reporting form. So patient detail, suspected drug, suspected reaction, reporter detail, everything should be reported. So all suspected reaction, including minor one, as I have said, change in frequency and suspected drug food reaction, ADR associated with drug withdrawal, ADR related to medication error, everything should be reported. Who can report? As I have said, patient, patient relatives, healthcare professional, specific population, even the patient relative, they have got a helpline number, PVPI helpline number where they can report. Manufacturers, those big companies. Like today, I am also thankful to Integra Ventures for giving me the opportunity to speak here. Every company, they have got some units where they can report all those things. So regulatory authority, they can report. Then industry, manufacturer, health professional, general public. Report to whom? Okay. Then we have the version of reporting is through a software which is known as VisiFlow. Okay. VisiFlow allows capturing the causality assessment while detecting adverse drug reaction. We will be discussing some term like causality assessment, not casualty assessment. Causality assessment may be, that is again determined by NCC, WHO Uppsala Monitoring Center guided sentences, where they are said to be predictable, they are said to be probable, they are said to be definite, non-probable. These are the terminologies which are used. I won't go into details because there are different terminologies everywhere. You all are aware, taking into consideration that you all are aware regarding the adverse drug reaction monitoring. So causality may be certain. That means with the giving of this drug, this manifestation has occurred. So this is certain. Probable. They have given so many polypharmacy medicines. Out of this can be probable. Possible. Yes, out of this may be the possible reason. Okay. So these are the terminologies which has been taken from WHO, UNC, Uppsala Monitoring Center, causality assessment criteria. There are also certain terminology which is depicted as unlikely. That means very rare phenomenon, very unlikely. We used to say conditional. That means with the stopping of the drug, the signs and symptom has gone away. Again, re-challenge with the giving of this drug again the signs and symptoms may appear. Okay. So, in nutshell, I can say pharmacovigilance is a dynamic clinical and scientific discipline. ADR reporting is one of the most important duty of every healthcare professional, I would say. Majority of global information related to ADR arises from Western country, but we are also not lagging behind. We are also reporting. Every center is reported, and successful implementation of pharmacovigilance center can minimize adverse drug reaction. This can promote rational use of drug, ensure safe drug to the healthcare community. So these are my reference. Thank you. Now the house is open for questions. If you have any doubts or anything, feel free to ask me. Samigiba? Thank you.
Thank you, Dr. Chowdhury, for such a remarkable and informative session. There are a few announcements, like we have given a feedback form in the registration kit. So kindly fill it up and keep it ready. our representative will come and collect it from you. And there is also be a register being passed on to fill your details. So kindly fill it up. And so that we can arrange the certificate, we'll keep it ready, certificate organization wise. So the sixth session of today's program, which is the last session but not the least, the topic of the session is medication safety in emergency by Dr. Sashiba Barman, head of the Department of Emergency and Trauma Center, Namecare Hospitals, Guwahati. Dr. Barman, having 13 years of experience in the field of emergency medicine, and is also the visiting faculty, DND Emergency Medicine, Apollo Hospitals, Guwahati. Dr. Barman is American Heart Association certified basic life support and advanced cardiovascular life support instructor since 2017. She is also a CAHO certified patient safety officer. She is also a National Skills Development Corporation certified emergency medical technicians faculty and a lead instructor EMT basic and advanced courses by Learned Skill. I would like to invite Dr. Sashiba Barman onto the stage. I would request Ms. Joyshri Saikia to felicitate Dr. Barman.
Lecture, right? So at the onset, I take this opportunity to thank Integra Ventures for giving me this opportunity to speak here, and really privileged to share the platform with my teachers, Dr. Bhabesh sir and Dr. Urmi Chowdhury ma'am. They were my teachers, and indeed, every day is a miracle, as sir said, and today is indeed a miracle for me to be here along with my mentors, right? So it's just the last session, and by now this can be taken as a recapitulation of whatever you have learned the entire day, right? So the World Patient Safety Day concept was actually first established in the year May 2019 in the 72nd World Health Assembly resolution, where the global action on patient safety was discussed, right? And it is one of the 11th official global public health campaigns which is undertaken by the World Health Organization. So patient safety, it actually comprises of the actions that are undertaken by individuals as well as the healthcare organizations to actually protect the patients from being harmed by the effects of the healthcare services, right? So patient safety is actually to protect the patient from the harmful effects of whatever medical treatment that we are providing. And long back in the year 2006, the Joint Commission International, they have rightly included the clause of improvement in the safety of high alert medication. So this concept of medication safety dates back way long to the year 2006, right? And we all know that medications are the most widely used interventions in the healthcare. We can never think of treating a patient without the medications. And according to the report of Joint Commission in the year 1995, so the medication related harm, they constitute the highest proportion of the preventable harm that is that happens during the treatment of a patient, right? So I think by this time you all know what do you mean by medication error. But again, to repeat, medication error is any error that can occur at any point of the medication process, right? It can be during prescription of a drug, it can be during the dispensing of a drug, or it can be during the administration of a drug, but irrespective of whether that thing has led to any adverse consequences or not. So any near miss event during administration of a medication is also a medication error. Okay? So thereby the WHO has rightly taken up the slogan of medication without harm for this year World Patient Safety Day, and medication safety in emergency, right? Why medication safety in emergency is given as a separate entity, right? So we have any nurses who work in the emergencies? Anyone over here? Okay, no. So, what one should understand is that the emergency department is actually the interface between a hospital and the community, right? So the patients that arrive in the emergency are in a very critical state, right? And the attendants or the people who come along with the patients are very emotionally subsurged, right? So there is a very chaotic situation, as you can see in the picture. The entire emergency at any point of time is very chaotic, right? And in that chaotic situation, anything, any ailment, right? And the actual condition may be something else, actual disease may be something else, and the treatment that we are providing can be of something else. So there is a whole lot of chaos that happens in the emergency, right? And these patients, the emergency patients, are the patients where we cannot even spare a single moment of time, right? They need immediate attention and treatment. So thereby the nurses, the ED nurses who works in the emergencies should have a standardized method or standardized protocol for providing these medications that are commonly used in the emergency to prevent the medication errors. So medication error in the ED is estimated to range from around 4% to 14%, which is very high, right? Although there is shortage of researchers that is being carried out in the field of emergency, but the researchers which are still being conducted, they show that the steps where the medication error can occur is due to administration of a drug to a wrong patient, or it can be in the wrong dose, which can be an overdose or an underdose, or it can be the wrong drug that to be delivered to a patient, right? But why? Why does this happen so frequently in the emergency? There has to be a reason, right? Okay. So what one should understand is that any patient in the emergency receives a whole number of medications, right? Not only one medicine. There'll be patients will be receiving around 3, 4, 5 medications at the same time. Since they are critical patients, most of the time the medications are given intravenously, right? And they will be the high alert medications, right? And hence they need to be handled appropriately. And I sometimes really feel pity for the emergency nurses because like they need to know a whole number of drugs, right? They should know the drugs that will lower the BP, they should know the drugs that will increase the BP, they should know the drugs that will reduce the heart rate, they should know the drugs which will increase the heart rate. So just imagine the number of drugs they should be knowing to properly use those drugs in the emergency. ED overcrowding, yes, it is almost impossible to maintain a constant patient-nurse ratio in the emergency, right? With one nurse handling 3 to 4 critical patients. The nurses who works in the ward can say like, we handle 5, 6, 7, 10 patients at a time. Indeed, that is true. But emergency, you should remember that each patient is critical, right? And handling 3 critical patients at one point of time, the chances of medication error increases. And lastly, as ma'am has already said, thanks to us, with the time constraints, this is what we do. Poor nurses. Yes? Apart from this, there are few distracting factors for the nurses, right? Multiple orders. Now, one doctor sees in the emergency, there is a referral from another doctor, 3, 4 doctors come, 3, 4 doctors give 3, 4 orders, so nurses are confused which drug to give, where. They have to answer a whole lot of phone calls, don't tell me. Right? Noisy, chaotic emergency. Everybody shouting at the top of their voice. The doctors, the nurse sister in charges, the attendants, right? They have to replace the cart medicine. Every time the crash cart is open, right? They have to replace it immediately, right? Patients come in shock and it is so difficult, so very difficult to find a vein at that point of time. So there will be technical problems during administration of the medications. And yes, the code blue is running in the hospital. Anytime you are busy in the emergency, code blue, yes, rush for receive the patient, right? And definitely, we have so wonderful attendants. So they'll be definitely allowing us to give all the medications because we are all exposed. In the emergency, it's like in the ICU and emergency are same only with a small difference. Both the centers to treat critical patients, but in the emergency, the attendants can see whatever is being done to the patients, right? So definitely non-cooperating attendants, and lastly with the NAPH, whole lot of documentation. So with this burden, with this amount of burden for the ED nurses, the chances of medication error is definitely very high, and we accept it, right? But you may say, so what? How do you say? this will lead to medication error. We all work like this, right? We all know by this time, right? The medication use process. So the medication use process comprises of these 4 steps. One is the prescribing, the dispensing, administration of the medication, and the monitoring after administering the drugs. So with the above scenario, the chaotic emergency that you saw and the burden of work the emergency nurses have, any of this process can go wrong. And that is why the incidence of medication error is so high, it's reported to be so high in the emergency, right? So let's see one by one and how do we prevent it. So by this time we all know what is prescribing medications. So it is basically choosing an appropriate medication for the patient, and apart from choosing the medication, it is also selecting the administration route, the doses, the timings, and the regimen of the drug, right? And then communicating this drug to the ED nurse as well as to the attendants to make them understand that this drug is going to do this, and above and all the documentation. So this entire thing comprises of the process of prescribing medications. So in the ED, the prescribing errors that commonly occurs are incorrect drug selection for a patient, right? Most of the patients are critical, they are brought in a hurry. The attendants, they fail to bring the previous medication charts. So we as a doctors, we are not able to elicit a proper history, we are not able to get the proper drug history, so we cannot decide what are the contraindications for this drug, right? And whole lot of informations like allergies, comorbidities, and everything can be missed. And when those are missed, we may prescribe a drug which is actually contraindicated or which can actually cause harm to the patient, right? And then the look-alike and the sound-alike drugs, right? So these drugs are commonly used, and then I say injection, dexamethasone IV, and the nurse in a hurry will be picking up the bottle of phenytoin because both of them look alike, right? And again, it is advised that start injection noradrenaline infusion, and then in the noisy, chaotic environment, injection adrenaline infusion is started because they sound alike, right? So these are the errors that can arise due to prescription. Second is errors in quantity and indication. Again, thanks to our doctors, we have very legible way of writing the prescription pad, and we are very famous in giving ambiguous orders, right? But I don't blame the ED doctors also because there's a time constraint, but definitely with ambiguous thing, we just say that injection levetiracetam 500 mg. Now the sister will be looking at us, okay, sir, IV, stat, over 5 minutes, right? So these are the orders, the ambiguous orders or documentation from the ED doctors. And yes, something like this, where the doctor has actually written digoxin 0.5 mg, but it is read as digoxin 5 mg. Yes. So it is always advisable to write 0.5, right, preceding leading zeros, right? And then the same thing can happen when we write 1.0. So if the point is not visible, then it will be interpreted as 10. Right? So to avoid the prescription errors in the ED, so that's why the NABH has very rightly emphasized on the electronic prescription. Everything should be in the system generated prescriptions, right? So that to a great extent will reduce the prescription errors that can occur in the ED, right? And the last, prescription of a contraindicated drug. As I said already, incomplete history, right? So it is very difficult to actually understand whether the drug is contraindicated or not, or if the patient have any allergies for that drug. The second is a dispensing error. So this is a picture of the pharmacy of any hospital, right? Whole crowded with OPD patients, with IPD patients, right? And the poor fellow from the emergency will be waiting somewhere with the prescription, right? And the pharmacist will be by the time so overwhelmed with whatever he is doing that he might give a wrong drug, he might dispense a wrong drug at that point of time, right? So it is advisable that if possible create a separate queue for the emergency patients in the pharmacy counter, a separate counter, so that the dispensing of these medications is easier, right? Look-alike and the sound-alike drugs, very rightly put by NABH, that they should be physically apart so that we know which drug is in which slot. Separate stock for the commonly used emergency medications in the emergency is usually advisable, because by doing this, the nurses, they know that this drug is here, right? It is kept here and they check it regularly. So by reflex, they'll be knowing that if I say injection atropine, they know that, okay, injection atropine is here and they can get it and can inject it to the patient, right? And dispensing safe, systematic procedures for dispensing these medicines is of utmost importance. Third step, administering medications, right? That means administering medication is obtaining the medication in a ready-to-use form. So this usually involves calculating the dose, mixing with the right diluent, labeling it, right? Keeping the preparations, and sometimes before administration, checking for the allergies and also documentation. And for this, we all know the 5 R's of medication safety: the right drug, right patient, right dose, right route, and the right time, right? But in this chaotic environment of the emergency, as you can see, whole lot of chaos, that's what we have been saying. It can very well happen that you have prescribed a medication for bed number 5 and the nurse has gone and given the medication to bed number 4, right? So it's a wrong patient, right? You said 500 milligram IV stab and the nurse heard 500 milligram IV whatever, and the drug is continuing for the last 10-15 minutes, right? It can be a wrong drug. You advise injection levetiracetam for bed number 5 and the nurse has given the levetiracetam to the patient who is in bed number 6, because it is all chaos. She's not hearing properly, right? Wrong route, dexamethasone IV, and she ends up giving it dexamethasone IM. All this can happen, right? So, and the last is inadequate communication, because we doctors, I take that onus on our doctors, we are very good in giving orders, right? So we will just say, oh, ठीक है, give injection. क्या देना है? Amiodarone दे दो. अब amiodarone दे दो, कितना दे दो? How much to give, right? So inadequate communication. Again, there can be errors of omission. Now with the entire load, a poor nurse, she is taking up 2-3 patients, and a doctor has advised 2-3 medications for all those 3 patients. There is a high probability of omission. She forgot to give one drug, right? Incorrect administration technique, and sometimes there can be a deliberate violation of the guidelines which are being given by the doctor. Again, failure to check the patient's identity. Time constraint, everything in a hurry. Jaldi, jaldi, fast, fast, fast. I need treatment fast. Every patient in emergency requires treatment fast, right? So you forget to identify the patient before giving the injections. And again, the noise, the interruptions of the ED, yes. And again, the wrong calculation. The wrong calculation either can be from the doctor's side or from the nurse's side. There was no cross-checking and the drug was administered in the wrong dose. So these are the errors that can happen while administering the drugs in the emergency. So we can minimize some of these errors. So always make it a point, however busy is your ER, it is always anywhere when you administer a medication, please check the patient's identity before administering the medications, right? Make sure. Ensure that the drug calculations are proper, right? If you have any doubt, just cross-check with your senior nurse or just cross-check with your doctor. Ask the doctor at any time if you have doubt. Sir, did you say 500 mg or did you say 1 gram? Right? So always cross-check before you give the drug. Make sure that the patient, the prescription and the drug you are talking about is of the same patient. Why this happens more in the emergency? Because a patient is put in bed number 4 and then you gave some injections and then the patient is advised ultrasound. The patient goes to the ultrasound room. The next moment some other patient comes and that patient comes and occupies that bed, right? So now if you don't put the documents properly, so you won't be knowing, because the doctor will be saying bed number 4 only. Yes, so if you don't keep the documents proper, you won't be knowing which injection you have given to which patient and the documentation might go wrong. And please ensure that however busy you are, however many patients you are handling, the medication should be given at the correct time. And minimize the interruptions. Like, don't get distracted by whatever is happening in the ED, right? When you are administering the medications, be careful. Give that 2-3 minutes only to the patient without getting interrupted, right? The last process is a monitoring, where we, after administering the medications, we monitor the patient, right? And then we document the findings of this monitoring. So there are a few population at risk right, whom we should be very careful and we should undertake monitoring for these patients. Number one, patients who receive multiple injectables, most common in the ED, right? Any patients who have another comorbidity, especially diabetic, hypertensive, or pregnant female. The patients who cannot communicate on their own, like the patients who are on ventilators, okay? The patients for whom you're receiving orders from multiple consultants. One consultant saying give this, other consultant saying give this. One consultant is saying give IV, the other consultant is saying give IM, right? Next, the patients in the emergency who are in altered sensorium or who cannot communicate well. So please monitor these patients carefully. And last but not the least is your pediatric patients, right? Because in those patients, we need to calculate the doses, right? So very careful when we monitor these patients. And despite however vigilant you are, there is the probability that there will be an error. And whenever there is an error, don't get scared, right? As sir said, it is not to blame. Kyun kiya? Why did you do? Yes? Kyo korisa? Right? Not that. The aim of the reporting is we prevent these errors from happening in future. So immediately inform the matter, right, to your senior or to your in charges, right? And an incident report form should be filled within the 24 hours of any medication error. But always remember that this document should not be kept in your medical records. Okay, it is not something which should be kept in the medical record, otherwise we will end up in litigation. So incident report is something that should be kept separately and it has to be given to the quality team and not kept in the medical records. So it is always a good risk management to report all medication errors, including mistakes that do not cause any obvious harm or even near miss. So you might think, I didn't give the medication, I just realized it before only, right? Why should I report it? But make it a point that you report the incident so that in future you are careful that you do not repeat the mistake twice, right? So we all know that IV pharmacological administration, it represents one of the most important responsibilities of an ED nurse. It is rarely that an ED nurse gives any oral medications, right? It is always the IV medications and it is always the high alert medication. So if that medication reaches the patient, then there is a chance that that will be a lethal drug for the patient, right? We might not be in a position to save the patient if it is a wrong drug to a wrong patient, right? So it is always advisable that we should capture the medication errors in the ED before it is given, before administering it to the patients, right? And to minimize the risk of error, the up-to-date information must be readily available to the ED nurses, and this can be achieved if we prepare the protocols, if the ED has got the proper protocols for the commonly used medications, right? If the prescriptions are computerized generated, then it is very, very easy for the ED nurse to administer these medications. And we should also try to come up with the medication sheet, especially for the emergency, where actually the preparation of the medicine is given, like which inotrope to be mixed with what. Like injection dopamine should be diluted with normal saline, but injection noradrenaline has to be diluted with dextrose normal saline. And that might not be known to a new nurse, right? So if we have a proper system where it is documented that if you are using this, you should dilute with this, right? Then it is very easier. The medication error can be prevented, right? Again, the correct rate of administration. Now the doctor will be saying, give injection nitroglycerin 5 mg per hour. And the nitroglycerin ampoule comes in around 25 mg. So how to prepare this? Yes? So that might lead to an error. So all these, how to prepare the commonly used medication should be in a printed format and can be kept in the emergency, in the walls of the emergency, so that it helps the ED nurses and there is the risk of medication error reduces. Pediatric, I believe Dr. Partha has spoken in details, but pediatric patients form an important aspect of the emergency, and for these patients also we should have separate protocol based on their weight, right, and also the rate of administration. And moreover, the ED nurses should be trained in giving the Venflon or the cannula to a pediatric patient, because it is very difficult to insert a cannula, right? So special training for the pediatric group of patients in the emergency, right? And in the emergency room, few of the do's and don'ts that one should follow if you happen to work in the ED. Do not accept any telephonic orders from anyone, not even the consultant, right? Because you might tend to misread the instructions, okay? Before administering the medication, just take 1 minute, confirm, identify the patient, cross-check for allergies if he can talk, right? And then administer the medications. I know you'll be very busy in the ED, but yes, definitely spare that 1 minute and get the things correct, right? If you have any doubt, do not give the medication. Ask your senior, ask the doctor. Repeat, keep on asking 2-3 times, but never give a wrong medication. Calculating the dose, be careful. If you have doubt, please ask your seniors or your doctors, right? Minimize your interruptions during giving the medications, right? Document everything. So it's not that after giving the 5 medications for all the 3 patients, I will document. No. Once you have finished giving medication to your 1 patient, document it. Then go to your next patient. At any point of time, if you land up in any error, report it, right? And analyze your performance and always learn from your mistakes, right? So every emergency department should have a systematic way of first dispensing the medications and then the administration of the medications. Regimen of a commonly prescribed drugs in the ED should be made into a protocol and hanged in the walls, and the nurses should be properly trained, right, regarding the pharmacological indications. So one of the commonly used drug is adenosine. So one should know where is adenosine given, what are the contraindications, right? And then the side effects, because adenosine can cause bradycardia, right? So what special precautions you need to keep? You need to keep injection at drop-in ready, so that if a patient goes for brady, you can give the injection at drop-in. Dose, right? And the way of administering the drugs, right? Each drug is different. Most of the drugs used in the emergency, the route, the dose is different. So the ED nurse should be specially trained, regular classes training should be conducted so that the chances of medication error reduces, right? So the take-home message for today is medication error is very common in the emergency, the incidence being around 4 to 14%. It is all because the patients in the emergency are critical patients, need to be attended immediately. The environment is very chaotic, right? We all have tight constraints. The nurse-patient ratio cannot be maintained, and the use of multiple high-alert medications increases the chances of the medication error in the emergency. So to reduce the chances, always have a systematic way of prescribing, dispensing, and administration of the medications, right? Regimen of the commonly prescribed drugs should be made available in the form of a protocol in the emergency. If any incident happens, don't hesitate to report it, right? So that you don't repeat the mistake in future. And last but not the least, combination of the theoretical and clinical knowledge of the ED nurses is definitely the need of the hour, and we need to really focus on this aspect, right, to reduce the incidence of medication error. So any questions? So thank you so much.
Thank you, Dr. Barman, for an incredible, thought-provoking and inspiring presentation. What feels like the end is often the beginning. So here we come to the end of the one-day management development program on medication safety. Thank you to all the eminent speakers, guests, faculties, participants for your presence here at this program. On behalf of Integra Venture, I offer my regards to all the speakers, delegates, participants, and the people joining us. I convey my regards to the guest of honor, Dr. Harsha Bhattacharjee, sir. Thank you so much, sir, for accepting our invitation and coming over to the program. I would once again thank to all the speakers for their time and sharing their areas of expertise among the participants. I would like to thank our co-sponsors, StratSpay, IT support by Rely Healthcare Technology, and the support from Sri Sankaradeva Nethralaya team in organizing the program successfully. A special mention to Mr. Chandan Hazarika, Mr. Partha Pratim Barua, Mr. Raman Kakoti of Nethralaya Hospital, I would also like to thank each and every member of Integra Venture for making this program successful. Thank you once again, and I appreciate all of you who made this occasion a reality. To conclude, I wish you all a great success in your pursuits. Let us have a photo session. I request the dignitaries to come over the stage, and maybe the participants also can join us. The Integra's team, I request all to come to the stage. Where is the register? Can I have the register?
আজি আমাৰ ইণ্টিগ্ৰা ভেঞ্চাৰ্ছৰ ফালৰ পৰা শংকৰদেৱ নেত্ৰালয়ৰ সৈতে আমি ৱৰ্ল্ড পেচেণ্ট ছেফটি ডে আজি আমি অৰ্গেনাইজ কৰিছিলোঁ, য'ত আমাৰ বিভিন্ন ডক্টৰ্ছ বা আপোনাৰ এডমিনিষ্ট্ৰেটিভ মানুহবিলাকে জইন কৰিছিলে। ইয়াতে আমাৰ নেত্ৰালয়ৰ শ্ৰী হৰ্ষ ভট্টাচাৰ্য
खुशबू शर्मा, हाइबा लखले, निहारिका देवरी, मोनिका, पूजा तपोक, आर्मी, शेरिंग ड्रेमा, मिंचेंग डोंगेल, वाइकोम चानू, अनिशा, सेंट जॉन्स, याती, आर्या, पूजा सिंह, निहारिका देवरी, मुर्बिना बेगम, रमनदीप कौर,
It's done now.